People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right, I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However,
Hello， 各位大家好，早晨。Good morning, everyone. 我介紹我自己先。My name is Nida, and I'm the Program Director of AIDS Concern。大家好，我叫 Nida， 我係關懷愛滋嘅項目總監，亦都係今日大家嘅司儀。咁好高興，好歡迎大家嚟到我哋今日嘅 conference 啦。I'm so thrilled you're all joining us today. On behalf of AIDS Concern, I would like to officially welcome you all to our annual conference. 我哋今日嘅題目咧好特別嘅。So the theme of this year is From Science to Society, Addressing Disparities in HIV and Sexual Health。咁點解我哋會有呢個嘅題目呢？ So this year we want to introduce new perspectives to inquire the issues of HIV/AIDS。我哋今年咧希望咧有多啲唔同嘅專家啦，其實就希望可以帶俾大家啲新嘅角度啦，去探討 HIV/AIDS 啦、性健康嘅呢一個 issues 嘅。咁所以咧，我哋今日嘅 conference 嘅 structure 係好特別嘅。我哋咧就會係有3部分啦，而嗰3部分嘅組成咧，正正就係性健康3個好重要嘅元素，包括咗 physical health、mental health 同埋 social health in relations to sexuality. So this conference is structured in 3 sections. It's based on the 3 core elements of sexual health, which includes physical health, mental health, social health in relations to sexuality. For each of this section, our speaker will guide you through to explore social and structural determinants impacting one's sexual health. We'll also inquire intersection between different areas of health, sexuality, and sexual health. We will also share and exchange ideas on building a sustainable, inclusive, and equitable environment and service model. 我哋都希望啦，可以多啲機會啦，去探討啦。其實喺我哋講緊探討 HIV 性健康呢個 issues 咧，背後咧其實有好多唔同嘅一啲嘅元素啦、大環境啦，其實係會影響到我哋嘅性健康。希望就從而可以探討多啲有一個咧嘅環境，我哋嘅 service model 啦，點樣可以再做得好啲，去可以提升大家嘅性健康。So by starting this dialogue of all these topics today, we hope to inject new energy into our HIV responses, break down the service silos, and join hands with you all to promote holistic sexual health. So it's a full day event. 你哋睇到本 book 啦，嗱，今日係成日嘅 event 嚟嘅。So let's get started with an opening speech from Jerome, our Chief Executive of AIDS Concern. 有請 Jerome。
Good morning, Dr. Wong, Mr. Chu, Professor Kwong, distinguished speakers, fellow participants and friends. It gives me great pleasure to welcome you all to AIDS Concern Conference 2024, titled From Science to Society, Addressing Disparities in HIV and Sexual Health. We aim to reinvigorate our response to HIV and other sexual health issues. By bringing together academic experts, health professionals, social workers, and community health leaders, we strive to break down service silos and take concrete actions to address social and structural determinants of health. As an NGO that works at the forefront of the local battle against HIV, we have seen those scientific achievements in HIV research in the last 4 decades that have led to tremendous progress in both treatment and prevention of HIV and AIDS. And it is now within our reach to end the epidemic, but we can't just rest on our laurels. We need to rethink and re-energize our response not only to HIV, but also the broader issue of health inequities. The World Health Organization has made it very clear, and I quote, "Health inequities are systemic differences in the health status of different population groups. These inequities have significant social and economic costs both to individuals and societies." Now that is the reason why we are here today. We look at the sciences and to exchange views on how to turn scientific knowledge into catalysts for service excellence and social betterment. Today's conference touches on a wide array of topics and covers the 3 core elements of sexual health, namely physical, mental, and social well-being. By studying new ideas and synergizing between different models, we can find effective ways to tackle health inequalities, thus making our society healthier and better. I want to take a moment to acknowledge and thank our esteemed speakers. Also, a big thank you to our platinum sponsors, GSK and Gilead Science, for their support. Today's event wouldn't be possible without their support and generosity. So let's join hands together to champion a holistic approach to sexual health and work towards a more equitable future. Thank you. And may I now introduce Dr. Bonnie Wong, consultant, Special Preventive Program of the Department of Health, to come forward and deliver her welcome remarks. Thank you.
you. Jerome, Travis, and Mr. Ju, distinguished guests, ladies and gentlemen. First and foremost, I would like to express my heartfelt gratitude to AIDS Concern for organizing this AIDS Concern Conference 2024. It is my great pleasure and honor to be invited to deliver the welcome speech for this meaningful event. If you read along the program, you appreciate how the organizers had thoughtfully brought together a distinguished panel of speakers who are going to share with us their vast knowledge and expertise in the respective domain related to the prevention and control of HIV under this meaningful theme, addressing disparities in HIV and sexual health. Well, this year, year 2024, is a special year, as it marks the 40th anniversary of the first HIV case being reported in Hong Kong. Throughout the past 4 decades, the government, health professionals, academicians, and the very, very crucial NGOs, and among them AIDS Concern, have made concerted efforts in the fight against HIV. Indeed, as my colleague Dr. Lisa Yip is going to share in her talk later today, we are glad to witness a steady decline of the newly reported HIV infections by 40% over the past 8 years, from its peak at over 700 cases in 2015 to less than 400 cases in 2023. I would like to extend my deepest gratitude to everyone who came before us and our peers with whom we are now working together for the contributions to the field. Their unwavering professionalism and tireless dedications have made a significant impact on the prevention of and treatment of HIV in Hong Kong. Well, despite this trend, as Jerome has already mentioned, there is in fact no room for us to be complacent. We are being confronted by multiple challenges, such as late presenters, the static, if not rising proportion of people who actually present late with advanced HIV disease, the disproportionate presentation among ethnic minorities, and the static number of cases among non-key populations. And above all, the stigma and discrimination that still exists despite 40 years of very promising medical advances. So my fellow teammates, I believe it comes the time when we have to work even harder, not on our own though, but join hands and work focusing on the intersectoral collaborations that we just mentioned, overcoming different social and structural barriers in order to address the needs of our clients and to narrow the gaps in our service provision. In line with this objective, I'm actually very pleased to share with you the government's new initiative, the Commons, Yattong, which provides a one-stop integrated service under the person-centered care concepts. As its English name implies, the Commons symbolizes the mission of converging the power of caring and inclusivity from stakeholders. And its Chinese name, Yattong, implies, we are actually working hand in hand with the service recipients. While the Commons serves to address the overall well-being of individuals that's been highlighted in this seminar, it is also highly committed to maintaining and fostering close collaborations with local and regional stakeholders, with a hope to contribute in cultivating a supportive, inclusive, and enabling environment for care seekers. And other colleague of mine, Dr. Heather Doe, will be sharing what the Commons does in the afternoon. Last but not least, allow me to extend my warmest welcome to our speakers and friends from Singapore and from Thailand. At the same time, I also look forward to the excellent presentation from our local partners who are to offer invaluable insights to the discussion today. In closing, on behalf of the Department of Health, I wish this conference a great success and all participants the most fruitful and enlightening experience, gaining not only knowledge from the science, but also bringing forth innovative programs to the society, addressing the disparities in HIV and sexual health. I thank you all.
Dr. Wong. Thank you, Dr. Wong. So now I would like to invite Professor Travis Kong, who is the professor of Department of Sociology, the University of Hong Kong, and who is also the chairperson of AIDS Concern Board, to come to the stage to say a few words for us. Thank you.
Good morning, honorable guests, speakers, practitioners, friends. It is my great pleasure to welcome all of you to come to our AIDS Concern Conference 2024, titled From Science to Society, Addressing Disparities in HIV and Sexual Health. This conference actually is really important for us because it marks a crucial milestone for AIDS Concern in the way that we recognize the intersection between scientific progress and advancements and societal impacts in the realm of HIV and sexual health. As AIDS Concern, our mission has always been to empower individuals living with HIV and AIDS, prevent new infections, and also to promote health and well-being of all individuals, particularly in the context of sexual health. So this conference is so important because it is the way that how we recognize the pressing need in terms of disparities in this field and ensure that scientific progress in some way can actually translate into tangible improvements in our lives. This conference is a really excellent platform to engage with cutting-edge research like innovative sexual health model and also evidence-based practices. We have renowned speakers from many different disciplines, such as like in healthcare, academia, and advocacy. So today you know that they will tackle and examine many different issues, such as like access to care, talk about mental health integration, social factors that leading to different types and forms of disparities, and also the unique challenges that some minority communities have been facing. And so together, I'm sure we will explore and also address and think about and formulate effective strategies in order to reduce disparities, combat stigma, and to ensure equitable access to comprehensive HIV prevention, treatment, and care. Okay. Please allow me, to express my really, really heartfelt appreciation and gratitude to our organizing committee and to our honorable guests and speakers, and also to our platinum sponsors, Gilead Science and also GSK, for their invaluable contributions to make this conference possible. Okay. So in conclusion, I welcome you all to come to and enjoy this conference, and I'm sure by sharing our collective knowledge and practices, we'll figure out a way how to reduce and address the different forms of disparities, as well as we can actually try to rebuild a society where every single one can access to health, to quality health services equally without discrimination. So really hope you all enjoy today's conference. So may I now invite Mr. Ricky Chu, the chairperson of the Open Opportunities Committee, to come over and to speak a few words.
Jerome, Bonnie, Travis, distinguished guests and friends, good morning. It is my honor and pleasure to be invited today to join you for this very meaningful conference. And from the Equal Opportunity Commission's perspective, the treatment for and prevention of HIV have undergone significant transformation since the first case of the infection was recorded in Hong Kong 4 decades ago, as Bonnie has mentioned. With advancements in the antiretroviral therapy, people living with HIV are now living longer and healthier, with AIDS-related deaths becoming less and less common. The availability of pre- and post-exposure, as well as self-testing measures, have also greatly reduced the risk of transmission. Hong Kong's response to HIV is undoubtedly showing positive results, as evidenced by the fact that the number of HIV infection reports has decreased for 8 consecutive years since its peak in 2015. As the Hong Kong Advisory Council on AIDS made clear in its latest strategies, the goal is to end the AIDS epidemic as a public health threat in this city by the year 2030. Yet, as medical treatment and prevention for HIV have advanced drastically, societal attitudes towards people living with HIV have not progressed at the same pace. Myths and misconceptions about HIV and AIDS remain prevalent. While people who are HIV positive are often faced with stigma, discrimination, and society exclusion. Evidently, such attitudes are detrimental not only to their physical health, but also to their mental well-being. Whether in the form of a joke, verbal abuse, or job termination, such a stigma and discrimination rob people's right to live a life of dignity. These acts can cause people to hold themselves back from seeking help and treatment, the delay of which will not only put the individuals in greater risk, but also cause a negative impact on the wider society's management of the HIV epidemic. The Disability Discrimination Ordinance protects people living with HIV from discrimination, harassment, and verification. As the public body tasked with the implementation of the ordinance, the Equal Opportunities Commission has taken a multi-pronged approach to combat the stigmatization of people living with HIV. In terms of enforcing the law, we have been handling complaints related to HIV and AIDS. By conducting investigation and assisting its conciliation, the EOC provides a channel for those living with HIV to seek redress when they have been discriminated against or receive less favorable treatments. Our complaint handling mechanism also enables us to monitor the patterns of discrimination and devise policy recommendations accordingly for broader change in the society. Prejudice against the stigmatization of people living with HIV often stems from a lack of understanding. It's therefore essential to tackle misinformation about HIV and AIDS through education. Through our engagement with stakeholders in different sectors, such as the hosting training workshops for employers, we have sought to educate the public on appropriate ways to interact with people living with HIV, enhancing understanding of their legal rights and protections, and promote their acceptance and inclusion. And we also see the education of the next generation as an indispensable step to eradicate the stigmatization of people living with HIV in the long term. As our own research has shown, there is, unfortunately, a lack of sexuality education in schools. We believe there needs to be a comprehensive reform of the current guidelines on sex education, and have included this proposal in our submission for last year's policy address public consultation. We are also making use of multiple channels, including the social media and the Equal Opportunity Youth Ambassador Scheme, for tertiary students to instill in the younger generation values of empathy, inclusion, and respect. Indeed, to truly transform the lives of people living with HIV, we need to correct misconceptions, challenge outdated thinking, and change the way society sees HIV. I've no doubt that the discussions and insights this conference inspires will move our society in the right direction. And I look forward to working with you all to make the vision of zero stigma for people living in HIV a reality. Thanks a lot.
So now we'll take a group photo together. So we'll have Jerome, Dr. Wong, Travis, and also Mr. Ju, and then we'll take a group photo together first. Okay. 有請幾位，影張相。多謝晒。好啦，咁我哋事不宜遲啦，我哋就進入今日嘅第一個 section 咧，就係我哋嘅 keynote lecture. So, without further ado, we would like to kick off our keynote lecture section. So we're very happy to have Professor Roger Zhong with us today to be the first speaker. 我揾Professor Roger Zhong 嘅時候咧，我就email 佢，因為我知道咧佢係一個好 dedicate 嘅一個嘅 scholar 啦，其實係探討好多有關 health equity 嘅呢個 issues 嘅。So when you look at our topic, we said like from science to society, addressing disparities in HIV and sexual health. 要明白咩叫 disparity 咧，其實我哋有啲 basic 嘅 concept 係要去一齊去研討一下嘅，包括譬如可能係我哋講啲 social determinants 啊、health equity 等等。So I'm so happy to have Professor Zhong today to share with us and equip us with all this knowledge to do our work. So Professor Zhong is Associate Professor, JC School of Public Health and Primary Care, the Chinese University of Hong Kong. He is also a co-director, CUHK Center of Bioethics, and Associate Director, CUHK Institute of Health Equity. He will share with us the knowledge and concepts on health equity. Professor Zhong, please. Thank you.
I'll be using this one, right? Yeah. Okay. Hello, everybody. Good morning. How's everybody doing? Good morning, of course. Ladies and gentlemen, it's really my honor to be delivering this keynote address. Oops. For today. I'm so sorry about this. I'm a little nervous. But this is a very important topic. When I got the invitation from NIDA and AIDS Concern, they asked me to give a perspective from the health equity angle to look at HIV and AIDS and sexual health. So this is what I'm going to do today. If you haven't heard about health equity, this is good because I'm going to make a case for health equity to look at sexual health today. And if you have studied or encountered this topic before, this may be familiar to you, but it will serve as a recap of some of the thinkings in health equity. So health equity matters is what I'm trying to get at today. And this is the aim for today. I'm going to describe the phenomenon of health equity and inequalities and introduce the concept of health equity to make a case why it matters and to illustrate the concept of social determinants of health. To argue why we should go beyond just the more conventional distributive justice to address the social determinants of health and to describe some strategies, overarching strategies to address social determinants of health. And at the very end, I will pose a challenge to every one of you today. So thank you, AIDS Concern, for the invitation. I would like to acknowledge my colleagues, research team, and PhD students, and also the Institute for Health Equity, and also the funders for my research work. So, health inequalities, 健康不平等, okay? So, let me give you some empirical evidence of health inequalities. So, this is health inequalities when you zoom out, right? This is global health inequalities. As you can see over here, this is on the x-axis is the GDP per capita, the wealth of a nation, and then on the y-axis, we have the health of the nation as measured by life expectancy at birth, right? As you can see over here, if you increase the GDP per capita for a lot of these developing countries, then the health indicator just skyrocketed, right? But then there will be a turn and it will plateau, even though there will be slight increase afterwards, right? But then it will only increase just a little bit, okay, for the developed countries. And this is famously called the Samuel Preston curve. Now, if we zoom in to some of those richest countries, as we see, they kind of plateau, what we see here is that if you put income inequality on the x-axis and the y-axis the same, health indicator, health problems, you will see that if the society or the country is more income unequal, right, the Gini index is higher, right, then actually there will be more health problems. The people will tend to be, on average, less healthy. Then if we zoom in to one of these developed countries, and in this case, this is the UK, all right? And the little dots are the neighborhoods. And on the x-axis now, we have the neighborhood income deprivation. So if you go along the line of the x-axis, you will become least deprived, okay? The more deprived are at the left-hand side. On the y-axis, we have the life expectancy. We see a couple of things. Number one is that deprived people, they die younger. And number two, the deprived people also suffer longer from disability. So they start to have disability younger. They live a longer life with the disability, but also die younger, right? So we call this a socioeconomic gradient in health because it's not a dichotomous concept. It's not like, oh, you're poor, then you will be worse. It's like talking about this gradient, 一個梯度, okay? As you go along, as you get wealthier, right, you're going to get healthier. So it affects everybody. The whole idea about socioeconomic gradient in health is that it affects everybody, not only those people who are labeled as poor. This is the US. We see very similar things, right? Income on the x-axis, again, as you get richer, the percentage of people reporting poor health gets lower. And in Hong Kong, what about Hong Kong? Okay, so these are some of those papers that we have done and a lot more, but I'm just highlighting some important key findings from my own research with my research team. We found that in Hong Kong, deprived people have worse general health than their richer counterparts. 66% of them are more likely to have worse physical health, and 83% are more likely to have worse mental health. The deprived also have greater risk for chronic diseases and multi-morbidity, meaning multiple chronic conditions. Right? People of education attainment of primary or below were 28.7 to 68.9% more likely to suffer from multi-morbidity. People with income less than median household income were 43.3% to 52.2% more likely to suffer from multi-morbidity. Jobless people were 63.9% more likely to suffer from multi-morbidity. And compared to smoking, which a lot of people know that is a public health hazard, it's only 36.7%, relatively lower than the deprivation, the harm of deprivation that it's going to do to you in terms of health. Now in Hong Kong, if you divided it by the 18 districts, we also see that if the district median monthly household income, as it increases, life expectancy also increases. So it kind of matters where you live, but probably a causal, it's a reverse causality. The people who are richer, they tend to live in richer neighborhood, and therefore they also have better health, longer life. This is another way of looking at it. income, again, as it increases, we also have the percentage of people reporting poor health getting lower, and we also call it a socioeconomic gradient in health. This is healthcare inequalities, right? Deprived generally have worse healthcare accessibility, about 2 times less likely to have regular source of primary care, that is your family physician, a first contact primary healthcare provider. All right. And if you're interested, you can download, these are online. We have, in this Institute for Health Equity, released a series of health equity reports looking at generally the socioeconomic inequalities in health, and then from a life course perspective. And then our third report is on environment and health inequalities in Hong Kong, and there will be more. And the next one, in the future, we're actually going to look at gender inequalities also. So these reports are actually done in the tradition of, one of the most seminal health inequalities report, the Black Report in 1980, which really put the whole agenda of health inequalities on the map for the first time. It was published in the UK by the UK Department of Health and Social Security, and is chaired by Sir Douglas Black. This is Peter Townsend. Oops, sorry. So there's no laser pointer for this, right? Okay. So there's Peter Townsend, okay, who actually was known as the guru of poverty research. You have to understand that back in 1980, at the turn of the decade, from 70s to 80s, a lot of people thought that they have won the war against, the most treatable infectious diseases. They have really won the battle against, diseases in general, and they believe that, with research and innovation and technological advancement, they can solve any problems. And in the UK, they have the National Health Service, and a lot of people were thinking, health inequalities, that's not possible. We have, one of the best healthcare systems in the world that is almost free of charge, run by the government, supported by government revenues and taxation. How could that be? Everyone can access healthcare. But lo and behold, with the inequalities in health, it was revealed that there are a lot of inequalities. And whether you're talking about infant mortality, we see the same thing, same patterns across different causes. Sorry for the low resolution, because I actually I scanned this out of the original Black Report, right? So the lower the social class, the less healthy. Whether you're babies or adults, we see the same pattern, right? Same pattern across different causes of death. The lower the social class, the less healthy, the higher the mortality rates. So people were shocked. So remember Margaret Thatcher. Margaret Thatcher was trying to kind of shove it aside, because, she just gained power during that time. And the media picked it up, and they're waving the Black Report in front of her. So that was why health inequalities, for the first time in history, was put very firmly on the map. So that was the history. That was some empirical evidence of health inequalities. Now we're moving on to the next concept, health equity. 健康公平啦, okay? So basically the question that we're asking is this: are these inequalities that we have observed unfair? 係咪唔公平嘅呢？呢啲嘅不平等。So let's make a quick distinction between the two concepts. Inequality and equality are dimensional concepts, usually referring to measurable quantities, differences in quantities. On the other hand, when we talk about inequity or equity, these are ethical political concepts. Right? There is a moral commitment to justice, 公義, okay? So it is an ethical issue， 係一個同倫理有關嘅一個概念嚟嘅。Justice. In the words of Sir Michael Marmot, who is very well known in this area in health equity research, this is, paraphrasing what he always say. When health inequalities are remediable, meaning treatable, but they're not treated, not addressed, not remedied, then they're unnecessary and therefore inequitable and unfair. Meaning, if we have the technologies, if we know the answer to cure people's diseases, but somehow they wouldn't be able to get it, they couldn't access it, and they're disproportionately affected by certain health outcomes, that's unfair because we know the answer. So here's the normative ethics question. Normative ethics means we're not basing these arguments on just empirical observational data. We're actually making an argument, 一個同倫理有關嘅 argument, okay? Normative ethics questions. And I got asked this a lot when I was doing, throughout this past decade of doing health equity research in my work. People would ask you this. Inequalities exist everywhere, right? This is our world called planet Earth, right? And it is very unequal, and we know that. So why does it matter to you that you have to do all these health equity research? Let me try to answer this question. Well, we have to look at some guiding principles. We cannot just be all skeptical or even cynical about this, right? So how do we move from cynicism to reality to progress is going to be the theme for today's talk. Well, one of them, I would say, well, let's look back at some of the guiding principles of biomedical ethics. In 1970s, by the end of that, Beecham and Childress released a book that is one of the most influential ones that we still use in medical curriculum to this day, called The Principles of Biomedical Ethics. And in that, they have outlined 4 what they called equally basic moral principles. Sometimes these principles can come into conflict and create moral dilemma, but nonetheless, they are very important, okay? Basically important that they say would be universally agreed upon by all people. They are respect for autonomy, 即係病人自主 respect 佢嘅自主 non-maleficence, that is the do no harm principle, 即係唔好傷害 beneficence, 要個病人得益 okay? Beneficence and also justice, 公義 okay? So we don't have to apply this only in clinical settings. We can also apply it on a societal level, especially when we're talking about public health, 公共衛生. Justice is what we're talking about today. It is one of the guiding principles, right? So let me go back a little bit to the definition of health, right? How do we look at health? And I really appreciate the outline for today's conference, that we are splitting it up into 3 dimensions: physical, mental, and social well-being. And let's not forget, not merely the absence of disease or infirmity. Now, on the other hand, this is the 1946 definition of health, first time that WHO, under the umbrella of United Nations, experts come together and formulate this definition. It's an important definition because it is emphasizing that health is not just about the physical. As a lesson from the Great Wars, actually, they understand that it is also the mental health and the mental well-being and also the social well-being of the people that really matters. And then, 40 years later, they further clarify this: health as a resource for everyday life. 係個資源嚟嘅 not the objective of living. 唔係生命嘅目的 okay? That's important. Health is a positive concept emphasizing social and personal resources as well as physical capacities. Because what they're trying to argue here is without health, we cannot pursue our life's goals or happiness. I think that's a very compelling normative argument there. And the argument is that is one that is based on justice and that health is a basic right. Health is a basic right. That's important, right? And the consensus is that each of the states around the world, nation states I'm talking about, have an obligation to protect and promote the health of their citizens, and in some cases, the health of non-citizens within the borders. And it is codified to include everyone, not only citizens, okay? We have the Article 25 of the Universal Declaration of Human Rights, Article 12 of the International Covenant on Economic, Social, and Cultural Rights, and also the General Comment 14 of the UN Economic and Social Council. This is Eleanor Roosevelt reading this out. Everyone has the right to a standard living adequate for the health and well-being of himself and his family. Quote, right of everyone to the enjoyment of the highest attainable standard of health. And here we have in the UN General Comment, the right to the highest attainable standard of health. So these are codified and so influential that in 1978, they created also the Declaration of Alma Ata, Health for All, which is adopted at the International Conference on Primary Health Care, and it was the first declaration emphasizing the importance of what we call PHC, now very well known, primary health care. All right? And this approach has since been accepted by all the member states of the WHO as the key to achieve the goal of health for all in all countries. And it also gives support to the policy direction of what we now call universal health coverage. But here, let me contrast UHC, which is universal health coverage, with primary health care. They're a little bit different because PHC is bigger than UHC, okay? UHC is one way to approach and try to achieve primary health care, but it's a little bit different because PHC is more encompassing. It extends beyond just the traditional healthcare system to other areas that promote health, including social policies, environment, lifestyle, etc. So, what do we have in Hong Kong? Here we go. Hong Kong, this is the overarching healthcare policy in HongOng. No one should be denied adequate medical treatment due to lack of financial means. 中文係沒有人因為經濟原因得不到適切治療. All right? So let's take a look at this healthcare policy. It is a policy based on the concept of universal health coverage. All right, so in Hong Kong, we do have universal health coverage because all the residents in Hong Kong can actually go to the public healthcare sector and get your treatments, and you will not be denied adequate treatment due to your financial situation. But we do have to try to answer this question. Now, how many people in Hong Kong are denied adequate health care due to lack of means? Are there any people who are denied directly or indirectly due to their lack of financial means? 即係有冇人因為經濟原因得不到適切治療啦？香港 You want to take a wild guess of the percentage? Anyone? I heard 20. Well, that's a little bit high, I would say. I heard 10 somewhere. It's around there, okay? So according to our study that we've done several years ago, it was 8.4%. I would say that this is estimated because the people who actually pick up the phone call or agree to do household survey, they are usually a little bit more open, right? So we are probably missing those people who are almost invisible in our society. 8.4%. Some people would say, that's not too high, but you know, if you do a calculation, that is 600,000 people, more than that, probably even approaching 1 million people if we say that it is underrepresented, underestimated, all right? So there are people, right? And again, this is universal health coverage in Hong Kong. There is universal health coverage in Hong Kong, but not achieving the goal of health for all yet, okay? Because PHC, again, is bigger. Primary health care goal for health for all is bigger, right? It is a passive, not an active system, because it is based on a non-denial rationale. But that's fine, okay? Because, you know, that is how services work, right? You have to show up to the healthcare system. And what is adequate? Adequate according to whom? And last but not least, this is the emphasis for today's talk, right to health care, right? Not right to health. It's really emphasizing on the healthcare bit, which is talking about distributive justice, not necessarily the broader social justice. So here's an empirical ethics question. Why would health inequality exist even with universal health coverage? Then we have to understand this concept over here. So in this allegory, imagine yourself walking on, alongside a river. You're just strolling along, and then you heard someone crying for help, in the river, because you have taken first aid, okay, and lifeguard lessons. You jump to the river, save the person's lives. You feel very good about yourself. That person also thanked you for saving his life, okay? But then 5 minutes later, there's another person. You do that again. You pull it up, but you're wondering, why are there so many people drowning, right? And the third person and the fourth person, you kept doing it, and then you're like, what's going on up there, right? Because river flow from upstream to downstream, so you look up. You look at the upstream, and then you realize that there are people who are systematically being pushed down the cliff, right? So that's the allegory. On the downstream, what we're doing here are services, healthcare services, but there are these structural determinants of health, right? And this is what we call social determinants of health. 健康嘅社會決定因素, okay? Dated back to 1998, Sir Michael Marmot and Richard Wilkinson, two very important people, were commissioned by the WHO to come up with the first publication to summarize all the major work on social determinants of health, to provide a guide. All right, so the SADA Facts, a seminal report. And with this commission, they came up with the framework for the social determinants of health, which I would like to spend just a little bit of time talking about, okay? So usually when we talk about the downstream factors, we're talking about material circumstances, behaviors, biological factors, and psychosocial factors. These are the usual point of interventions. Now, with social determinants of health, they are pushing it a little bit to the upstream. They're talking about these over here. Structural determinants of health, including governance, the policies. We're talking about not only healthcare policies, but also macroeconomic policies, labor market policies, housing and land. I mean, when I talk about housing, then everybody in Hong Kong would be like, yes, of course, housing affordability and health, they are related. And I have actually published a paper talking about that. So if you're interested, let me know. Education, social protection, and also, last but not least, culture and societal values. All these things would give you a distribution that is unique to your society of socioeconomic position that are going to be proxied by social class, gender, ethnicity, education, occupation, and also income, okay? Now, two things that I would like to emphasize. You see that health system, it's in the downstream. It is put over there on a purpose to remind everybody that people get sick, then they show up in the health system. So therefore, it is in the downstream, okay? In the upstream, we're talking about these policies, these governance, and last but not least, culture and societal values that I would like to say something about today. This is the Chinese version. If anybody want to, take a quick snapshot, please go ahead, okay? This is translated by myself. Okay, all right. Addressing it. How do we address it? How do we address these social determinants of health? And I think we have to think beyond distributive justice. 超越資源分配公義. You would realize that the WHO, when they released the 2008 report, it is actually directed to the government, right? These are policy-level recommendations, improving daily living conditions, tackle the inequitable distribution of power and money and resources, and also doing evaluation. But can we go beyond that? I like this illustration because I think I personally like it better than the baseball one that probably a lot of you guys have seen. Now, this is inequality. No two, there's one with more resources. But if you give equal tools to different people, still there's equality, but not actually equity, okay? So here you go. So someone is getting a longer tool, and we say that, well, that's more resources, that is distributive justice. But a lot of times we forget about the fences, the barrier. The barrier are the social determinants of health, and we need to think beyond distributive justice to tackle them, so that we can live in peace. And one thing that I always like to say is that justice is not a stagnant state of affair. It is a goal that we always have to pursue after. There's this ideology, this ideal form of justice that we have to pursue, but doesn't mean that the little progress that we made are unimportant, right? So there's no case here for complete cynicism and say, well, there's no justice in this world, so why pursue it? I think there's a strong case here because justice requires us to make little progress at a time, and that is fine, I think. So there are two overarching recommendations that I would like to give today, okay? So these are from public health and also from social studies, social sciences. The first one that I would like to talk about is this idea called population health strategy by the great Jeffrey Rose with his strategy of preventive medicine. So he kind of contrasts the high-risk strategy with the population health strategy. The high-risk strategy are actually intervening with those with high risk. He said, it is great, but the caveat is that you're only intervening with people in the upper end, right? It is much needed. They need the help and the interventions, treatments and managements, all that. But he believed that if we can shift the distribution, we will help more people. And that is probably what we really need. I think health equity really lends itself very well with the population health strategy because what he's saying is that we need to shift the population mean and the distribution from a more harmful environment to a less harmful environment. And by that, I not only mean physical environment, but also the social, cultural, and political environment. And the second one is from social science and gender studies, which I like it very much. It's from by Iris Marion Young. It's called The 5 Faces of Oppression. 壓迫的5個面向. It is beyond distributive justice because what she's trying to address is that there are other forms of injustice in our society that takes the form of exploitation, 剝削, marginalization, 邊緣化, powerlessness, 無力感, cultural imperialism, 文化帝國主義, and also violence, 暴力. And I don't mean just physical attack, but also verbal abuse, harassments, petty harassments, and different forms of violence that we can think of. So with that, we need to ask these questions, right? With exploitation, who are being exploited in labor that harms their health? How? Marginalization, who are being regarded as not deserving the same level of health protection as others and thus deny equitable access to resources, opportunities, and recognition. Who are being dominated by, say, capitalists, we do live in a capitalistic society, and professionals in institutional labor relationship, and how can that affect health? And Mr. Chu was just talking about job termination, right? This is something that we have to think about. Cultural imperialism, whose perspectives are being rendered invisible by stereotyping and marking them as the other by the dominant culture, and how can that affect their health? And 5, who are being physically attacked, harassed, intimidated, ridiculed, as a result being degraded, humiliated, or stigmatized. And are these acts somehow was legitimized to a certain extent in our social environment and culture? Sorry, I ran a little bit over time, but here's the conclusion. All right. I like to think of it this way. What does it mean by taking a health equity perspective? I deliberately wear my pair of glasses today to illustrate this, okay? We can always take off our own glasses, which probably represent your own perspective on things, that the usual ones that you take, and take on different ones. So we can take on, for example, infectious disease and treatments perspective, cure perspective, technological advancement perspective in terms of vaccination, right? These are all perspectives that are very well known in the HIV and AIDS and sexual health realm. Security, of course, and economy. Yes, for a lot of those developing countries especially, they really affected security and economy. You can take on the lens of resources and cost effectiveness, but also today I'm advocating for a lens, a perspective of health equity. You know, take off the other lens for just a little bit while, take the health equity lens and look at the problem at hand. And what you will see is that there are two things, right? High risk, as Jeffrey Rose put it, then we'll be focusing on socially disadvantaged and vulnerable populations, but at the same time, we can take a population health approach. And then the concepts that we've talked about will become very apparent with this approach. Socioeconomic disparity and gradient health and social determinants of health, including the structural determinants, and also that we have to change the social environment beyond just distributive justice. Here's some skepticism in addressing social determinants of health. Some people would say, well, not everyone is a policymaker. I'm not one. Well, we can always lobby them with a bottom-up approach. Only policies can change the distribution of wealth and socioeconomic position in the societies. Well, yes, but aware of these inequalities matter in our services. They can be taken into account. And here's a myth. Addressing social determinants of health is only a matter of distributive justice. And today I say no. It goes beyond distributive justice to address the different phases of oppression that these people may face in our social environment. And these are very relevant to sexual health. So here are the take-home messages. Health inequalities exist across countries and within countries. It is a matter of justice to address these health inequalities. Social determinants of health should be addressed in both upstream policy making and downstream services. And addressing these SDH is beyond the matter of distributive justice of healthcare resources, and we need to look at the broader social justice. So what's next? All right, how do we address SDH strategically? Well, we can look at what other people have done, and this is United Nations UN AIDS, Global AIDS Strategy in 2021 to 2026, and they have come up with a new approach, leveraging on 4 decades of evidence, and they believe that what's stopping the end of this HIV/AIDS pandemic is because of this lack of focus on reducing inequalities, right? Because inequalities facilitated the spread of the pandemic. And they have looked at the structural determinants of health, of HIV vulnerability, and identify key populations also. And of course, we also have the Hong Kong's HIV and AIDS strategies with 8 key strategic areas and also priority populations. We can all base our assessment on what we already have, okay, in the world and in Hong Kong, and think about this question here. Okay, based on what we have and the situation in Hong Kong. How would addressing the social determinants of sexual health specifically look like in the context of Hong Kong? This is a challenge that I would like to pose to everyone today, okay? I think everyone should try to answer this thinking about your own role, your own duty, your own responsibility, okay, your own position. What can you do to address the social determinants of sexual health in Hong Kong? And these are just some examples, but it can go beyond that, okay? So thank you very much. And here's my contact and all that information. Thank you very much for giving the time for me to talk about health equity of sexual health. Thank you.
Professor Zhong 拉到個咪好低。Yeah. Thank you, Professor Zhong. That was a really powerful keynote to share the concept of health equity and so all the key concepts of justice. I'm still digesting. It's a lot of concept, but I think it really touched the theme of today and help us to think more. Just not only stay on knowing about the knowledge and prevention strategy, but really think deeper of the issues. Okay, so now we would like to invite Dr. Ho Kingman, and the chairperson of Hong Kong Advisory Council on AIDS, to share with us the evolving landscape and the emerging challenge in the HIV/AIDS work in Hong Kong. So we'll come to the topic on our home city, to see what's happening and any of the challenges and opportunities in how we deal with the issues of HIV. So Dr. Ho, please. Thank you.
First of all, thank you for the invitation of AIDS Concern. Sorry. Okay. Thank you very much for the invitation of AIDS Concern to invite me to share with all of you and some of the work which is initiated by the Advisory Council on AIDS (ACA) in the past, and we are looking forward to actualizing some of the strategic recommendations in the coming years. But to start with, I really enjoyed the lecture of Professor Zhong. Okay, to give you some kind of information, I just write a very little article and submitted, which is one is divided into 2, is about 健康公平. Okay. There's health 健康公平 in the Hong Kong Economic Journal. This is 信報. The first part has already published, but the second part will be published, I think, tomorrow. Okay, you may go to the website of Hong Kong Economic Journal and use my name to Google to search, and you may read my very short, humble articles concerned about 健康公平. To start with, when I wrote an article, which is a CME article submitted to the Hong Kong Medical Diary, on HPV vaccination, okay, and dating back from many years ago, okay, and I think this is more than 20 years ago. The term health equality was used many years ago. Okay, I read the term health equality, but somehow in the recent articles, the term health equity was used. Okay, it comes across my mind. Why? What is the difference between equity and equality? I start to search in Google, and I learned a little bit of the differences between. I read the 3 photos, the baseball, the football with the fences, okay, and use it as an example to illustrate what is the differences of between equity, equality, equity, and eventually what is meant by justice. Okay, I mean, in the context of HPV vaccination, we're talking about what is targeted. You know, in the country we are vaccinating the primary school girls only. Okay, the P5 the first dose is P5 and the second dose is P6, primary 5, primary 6. But we're talking about whether we need to have a catch-up program. We're thinking of whether we should implement a so-called gender-neutral vaccination, and that's what about the health equality and equity. And the little article I submitted to Hong Kong Economic Journal is about the access to the very expensive no-food treatment for a skin disease, psoriasis. Okay, is what happens to this group of patients, the access to this type of novel biologic treatment? Okay, if you're interested, you can go and have a read and give me some kind of feedback to let me learn more. I learned a lot from Roger this morning. Okay. Okay. Yes. Next time. Nick. The green button. Yes. Thank you. Yeah. Yeah. Okay. 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 This is my background. Yeah. No, because given the interest of time, I will make my presentation very quick because some of these important concept has been gone over by Professor Zhong. Okay, this is a quick revision of current landscape and HIV, ACA, Hong Kong AIDS strategy 2022 and 2027. And this is the latest. Okay, this is this is the local HIV/AIDS epidemiological data. Some of the epidemiological data. You may notice that at 2015, the peak we have just passed the peak of the HIV. And in GIST, this is a summary table. I like to highlight some of the important key messages in this table. It says male is the predominant group of people infected with HIV, but we have a substantial portion of female. And then most of these local cases are ethnic Chinese, and the route of transmission is through sexual contact, in particular through men who have sex, amongst the MSM. We have a small proportion of people contract HIV through needle sharing. The people who injecting drug, the PI, the people who inject PWID. And the mother, we have still have a sporadic report of mother-to-child transmission. Okay, and this is a summary of the extract of this from some of the table. And the preference of the local study by PRISM is a local study, which is the estimated preference of HIV positive among the MSM communities is about more than 6%. Okay, but one of the important observations in our data is more than 40% of local cases are late presentations. Okay, late diagnosis, late presentations. And the performance of the treatment cascade in 2020 is roughly, the denominator is 8,000 people living with HIV/AIDS, and 94% of those people living with HIV/AIDS were aware of their positive HIV status. But I have a puzzle, but I'm not quite sure how to explain. If the percentage is so high, 94%, how to fit in the data, the observation of more than 40% of them are late diagnosis. There must be some kind of missing knowledge gap between these two figures. We have to look into it, to explain the so-called seems to be a little bit discrepancies. And 84% of these cases, they have access to, already started on antiretroviral treatment. Okay, but supposed to be more than 90% because it is very likely those who do not started on the ART in the local medical health services, they may not be the long-term local Hong Kong residents. So they have a positive test, but somehow they will leave Hong Kong. So I believe that this indicator we are also achieved the 90% 90% goal. 90% of those who are on treatment has been the virus well suppressed. And up to date for those who are working not in the non-local in this room or maybe some other internet. Okay, internet. In Hong Kong, the government provides antiretroviral treatment. It is up to standard. Okay. It is almost in the forefront according to international standard at nominal charge. Okay, the charging policy in Hong to this group of people is something like as if we're taking care of patients with diabetic hypertension with the nominal charge. Okay, and even then we provide there is a safety net. This is free of charge. Should they passes the means test by the social welfare department, the level of support. And just Bonnie gave us the inform the audience that there is a developing one-stop comprehensive medical link up to prevention, medical care, and everything. That software is developing in the special preventive special preventive program. They're developing. They're getting add on more and more with the gain of experience. And if you're interested, I would give you. If you are interested, you may just contact Bonnie to ask for a visit. Okay, ask for a visit to the Yat Tong clinic. Okay, should you have a good link with the MSN community? I think if Bonnie will welcome the visit by the MSM. Okay, for the service. Okay, am I right to say that, Bonnie? Yes. Okay, and this is the quick highlight of the current landscape. This is the shot of the so-called the key players. Okay, this you may read. Okay, you may read from the strategy published on the internet. But I give you a highlight. This is a CHP Center for Health Protection, DHR Health Bureau, and other government. The SPP, the Special Preventive Program, provides. It's a clinical program, public health program. Clinical program and public health program provides the policy support researchers, and also to support the scientific committee on AIDS and STI, and the advice part and partial before it is fully supported the AIDS Trust Fund. But now we also support, but slightly different. But the CHP have a separate team to support the ATF, the AIDS Trust Funds. Okay, and the clinical services are also provided by PMH and Queen Elizabeth Hospital. And there are other. It's not directed to people with HIV, but some people at risk, the so-called vulnerable population. Okay, this term vulnerable may not be so welcome by some of the workers or the people themselves. But I still use these old terms. Okay, and the social hygiene service and the narcotic division administration, the methadone program, the tuberculosis, TB and chest services, social welfare department, education department. They are all providing different kinds of. They have participated in the local HIV programs in different manner. And the advisory council on AIDS, okay, we have from stakeholders from various background, including Professor Sun, okay, from the CUHK. They, you know all this, Professor Sun. He is an academician with interest in gender issue and sexuality, okay, and a wide participation by different backgrounds. And advise the AIDS Trust Fund? Well, the AIDS Trust Fund there is four, in fact, three regular committee and one special project fund, which is an ad hoc one. And the EGP, it means the extra payment, okay, extra payment committee, and the publicity and public education committee, and the medical service and support committee. These committees are represented, the committee member are represented by, okay, and chair and represented by mostly non-governmental members. As you know, it's a little bit, you know, this is not 100% governmental. Not 100% governmental. They do all this vetting to vet the project submissions, and then grants the funding to support these activities. And from the financial year 1993 up to the financial end of the financial year last year, okay, slightly less than 1 billion, less than 1 billion have been already funded to support various projects, okay, including all these in work concerned about people living with HIV/AIDS, people who injecting drugs, ethnic minority female sex worker, and the male clients female sex worker, the transgender, and others. And more, this is some of more than 2 million condom has been distributed. But in fact, much more than that. Okay, this is the condom distribution. This is all funded by AIDS Trust Fund. But there, a lot of the NGOs, they have received support from the other funding, including, you know, the famous condom producer start with the D. Okay, okay. They donate in some point of time to donate the condom to the NGO for them to distribution. So the condom distributed should have been much more than above 2 million, and in context of outreach, and more than 700,000 HIV tests has been performed. As I said, should be much more than that, because some of these testing are not directly supported by ATF, but initiated by the NGO themselves. And this is but the point is these funding projects, this funding project not written here, is plot by project and by project basis. It causes some of the challenges of the NGO. Okay, what are the challenges for the NGOs? It is, you know, whether it is very difficult for the NGO to have a relatively long-term planning, staff development, okay? And very difficult for the NGOs to train the staff, to retain the staff, to train the staff. Yes, leader, not his. Okay, this is the challenge, okay? We have the NGO participate lots, very important stakeholders. Mainly in the local program is the so-called AIDS, the NGO with specific interest in HIV/AIDS. The participation of the mainstream NGO plays a small part, okay, mostly, as up to date. And but connected the NGOs are very, very, very important. It's where the people, the guy who really directly reached to the community people, and if they do the frontline work, okay, they really go to the bars and saunas, and to directly talk to the say an MSM, talk to the attendants, the service user of this sort, the gay bar or the gay sauna. Okay, from one time, this is a story. That's some years ago. Okay, the controller of Center for Health Protection, okay, said to me that, okay, well, Dr. Ho, you can actually go to if you are being invited to the gay bar to, you know, give a short talk about HIV/AIDS prevention or whatever, you are welcome to do that, okay? Okay, but eventually, if somebody asked me and I filed an application, and it is not, you know, not so welcome, okay? Not so welcome. After very serious consideration, as a government officer, they at the high level, they have the really other considerations of inviting of government officers to present, to talk directly, to go to gates on to engage in this health promotions activity. Okay, and the NGOs in particular is concerned. Okay, they have very innovative idea. The very innovative idea in their promotional material, which is quite welcomed by the community people, such as the Tong Sing. Remember? Okay, Tong Sing. Okay, okay, John, you know Tong Sing, the Tong Sing, and 恭喜你有梅毒. Okay. Okay. For somebody who doesn't understand what is the Tong Sing, why it is so interesting, and what is 恭喜你有梅毒. Okay. The AIDS concerned worker will explain to them why it is so innovative, so interesting. Instead, some of the older the government produced that our staff could be quite innovative, but at the same time we have very safe. We have to be very careful not cross a little bit the line, and then otherwise we will be in trouble. And this is innovation, and the NGO, they have a role, advocacy role, the advocacy role. Okay, and but for the advocacy, to sidetrack a bit, here I will talk about the slide later. In advance, show the messages in this slide later. Okay, the target of your advocacy work. The target of your work is who you are going to lobby, and what are your target audience? What are the target audience? I suppose your target audience is not Bonnie. It's not me. Okay, because we are in the same team, in the same boat. We're the same boat. We know everything. Okay, you have to. Okay, so in your advocacy work, remember your strategy. Okay, your strategy. Okay. And the challenges, we have long list of challenges. Long list, as well, dot in the front and dot at the back of this in this bullet point. Long list, and but I just highlight some of the very important challenges. Is include engagement of and support by stakeholders who actually have interest but not interested. The first interest is 切身關係, 利益關係. Okay, who are these stakeholders who have the 切身關係, 利益關係? Everybody you do. The local society, everybody in local society, including the common people, the lay people, including the government officers, including the management of the big giants, the industry, the pharmaceutical industry, and the commercial industry. Everybody, they should have 利益關係, 切身關係. Am I right? Okay, but not interested. Okay, you know what I mean. Okay, these are the important stakeholders. Okay, they're not interested, 不感興趣. We have to do that. Okay. And social marketing of the whole HIV/AIDS program. We are not very successful, say, in Thailand. In Thailand, they have launched a very successful condom social marketing, okay? Okay. The terms, I learned this term social marketing, dating back from sort of 30 years ago when I started in my HIV, when I was, deployed to SPP, to engage in HIV work. Okay, interesting term, social marketing, the condom social marketing. But it is not only the social marketing, not only limited to condom promotion, but for the whole HIV/AIDS program. Okay, this is very challenging. And the direct and active involvement of the targeted community people, the community people themselves. And then we have to engage them and obtain their support. Okay. These are the important challenges. And this is the current HIV response in Hong Kong. You know, the big circle is the whole society. We are the people at risk is a subset of the people in the whole society. Now we're doing the promotion, the behavioral change, the change of behavior, the content promotion, the empowerment and everything, testing, and providing the HIV combination prevention, patient center, harm reduction, approaches to approaches, and then eventually pick up that first diagnosis who have HIV and link them to treatment, and then we can use the prevention treatment as prevention approach to achieve the U equals to U and the holistic care, incorporating the targeted prevention among the people with an HIV. And just as Roger said, which we're doing to trying to shift the bell curve, the downward distribution curve from the high risk or at risk back to on the left side of the, to become sort of approaching the normal risk curve. Okay, this is I just learned from Roger. This is a shifting of the curve. Okay, and well, we are able to sort of achieve the triple 90 targets proposed by the UNAIDS. This is a summary table of this is all with figures. This is specific and measurable as a program surrogate indicators. Okay, you see this is the coverage, the number of condom, the coverage, the number of tests, the number of condom distributed, condom usage, and this is the summary statistic. Okay, have a look. Okay, this slide will happen again. Okay, later. Okay. And the terms of reference of our Hong Kong Advisory Council in AIDS to keep review local and international trends and development relating to HIV infection and AIDS, to advise the government on policies relating to prevention, care, and control of HIV infection and AIDS in Hong Kong, and to advise on the coordination and monitoring of programs on the prevention of HIV infection and provision of services to people with HIV AIDS in Hong Kong. This is the terms of reference of the Advisory Council on AIDS. I believe the key to success relies on wider community engagement, multi-sectoral, disciplinary organization, departmental, industry, national funding, lots of multi-sectoral responses, and active and even proactive participation, communication, and collaboration by people who are affected by HIV. Okay, this is the 2027 strategy. Okay, this is the approach: evidence-based community participation, the accessible and affordable by affected communities and whole society, cultivating a supportive and enabling environment, prioritizing funding and resources. This is the guiding principle. This is this slide. This is a recap of what we are doing. It's a so-called this is the community participation. But this is a recap. Okay, we have engaged the relevant NGOs, and different groups of consultation meetings, in various sections of consultation meetings, gather all their inputs, and the secretariat have summarized, collect and summarize their inputs, and eventually prioritize. Okay, prioritize, and this is the effort of the community. The effort of the community. This is the way we try our best to engage the community to have their view and inputs to put up and consolidate in the strategic paper. Okay, in gist, red, highlighted in red. The strategy is not my strategy, not the Advisory Council AIDS strategy, but the strategy of us, me and you. Okay. Okay. This is the strategy of the community. It is not only the strategy of the Advisory Council on AIDS. Okay. And this is very, very busy. To summarize, we have one vision. One vision 30. One vision 30. 4 objective, 6 target group, 8 strategic area, and 10 surrogate indicators. Okay, just like propaganda. Very easy to remember. It's one vision 30. four objective, 6 priority group, 8 strategic area, and 10 measurable indicators. Okay, I'm not going to be, given the interest of time, I'm not going to give individual detail of this, detail. And yes, this slide pops up again. Okay, I will draw your attention to the red, in the red highlighted thing. Okay, for this is what we have done in the strategy in 2017 to 2021. But now we have a new strategy from 2022 to 2022 to 2027. We have there in the so-called strategic area, there is 3, which is not mentioned. This is not mentioned in the report. Okay, is this 3? Enhance, promote youth health, sexuality education. Reduce and eliminate HIV-related stigma and discrimination. Mobilize the collaboration between government and the wider community, society to create change. These 3, okay, that is, well, I'm sure in the year 2017 and 2021, okay, we are doing these 3 already. But for some reason, okay, we are not able to consolidate into figures, to tell people what we have done. And by the end of 2027, we write down, a new term of strategic paper at the end of the 2027. I'm not quite sure whether we can put some of the indicator or a few words about what we have been done in this 3 particular area. Okay, this is the measurable indicators. Okay, this is very boring. Okay, you can go to the original papers to the strategic paper to individual to read them. Okay, but basically, there's a triple 95 and plus 1 the 90 the 90% and the triple 95 goal. We set it on the in the strategic paper. We believe that well, this is the evidence base, and we are continue to we are going to continually monitor, evaluate the effectiveness, and strengthen our partnership and connection with you and the community peoples. And well, I spent a very short time on the hot topics in ChemFund and ChemSex. Okay, this has been discussed in one of the meeting. It discussed in one of the meeting on the Advisory Council on AIDS. Okay, thanks, Lisa, Dr. Yip. Okay, to making the presentation in the Advisory Council in AIDS. This is some of the highlights. Okay, about ChemSex, which is a very important emergent issues to be and challenge we are facing now. Chemsex refers to the use of drug in a sexualized context by gay and other men who have sex with men, where specific drugs are used before or during sexual activity to sustain, enhance, disinhibit, or facilitate the experience. Basically, okay, the specific drug is mainly crystal ice, the GHB, G 水，大家知呢個嘅有個本地嘅名嘅，叫做咩啊？迷。Okay, yes, okay, 迷奸水 okay. This is the specific drug and the methadone, and this is specific drug of concern. Okay, well, we know that. Okay, there is so-called the negative effects of the chemsex is physical health, in terms of the during sex, in terms of the toxicity, the organ specific, the neurological, the neuropsychiatric and adverse effect of these chems, And during the chemsex, we have a good evidence to show that there's a high frequency of high-risk sexual behavior, including the number of sex partner, group sex, unprotected anal sex, and transactional sex. And this is the frequency of sexual behavior, and posing them at higher risk of contracting the all kinds of infection, sexually transmitted infection, hepatitis B, and hepatitis C, and HIV, of course. And the mental health issue, which is a cause and a result of the of the use of this substance. Okay, to start with, this patient may have depression, anxiety, they have some pressure, social life pressures to start with. So they engage in chemsex. But this kind of mental issue can also be a result of chemsex. This is mutually reinforcing type of relationship. This is the scenario. This is the 1-year and lifetime chemsex preference among MSM. This is the local data. Was estimated to be 12, 15, and 6 to 19%. Okay, it is not low, which is not low, but I have no idea whether it's whether it is an underestimation or not. But this is the result of some local study. And the chemsex is linked to the social media and gay social networking apps, okay, and social networking apps. So this is some of the findings derived from this from the local surveys. And the psychological factors such as relief of pressure, curiosity, and boredom contribute to the practice of chemsex, okay. But the question is whether chemsex can eventually address their pressure, can address their boredom, can address their neuropsychiatric status. The answer is I don't think so. Okay. This is also the data from the local study. The gist in this, the messages here is for those for those who have people living with HIV, they have a reported drug use behavior. Okay, and polydrugs is common, but there is 1/3 of them had coexisting mental illness. Most drug users never receive any form of drug treatment services. Okay, this is not only limited to the people living with HIV/AIDS who practice chemsex, but also for those not yet have infected with HIV/AIDS. The usage rate, the utilization rate of the drug treatment services was low. Okay. So in the strategic paper, it recommended integrated and multidisciplinary team approach to address this group of the chemsex issue and the capacity building. The capacity building is this is something that I observe is one of the NGO, the AIDS NGO, by training, they are not so well trained in counseling and capacity building, counseling and handling people engaged in drug using. For the conventional NGO who have focused on drug abuse, so drug abuse. Okay, the conventional NGO, they are not so. There's no well trained in HIV/AIDS, the gender issue and the HIV/AIDS issue. So we need to come together, okay, to mutually learn from each other, or to, if possible, to work together to work on this group of in this strategic area, okay. And the simple things is to also to let the AIDS services, including the clinical services, to facilitate early referral, pick up the patients and make appropriate referral, okay, to facilitate and to smoothen this route of referral, okay. And the challenges here, this is about chemsex, digital channel format of networking, and this is one of the challenges. this is not only for chemsex, this is for HIV/AIDS in general. The digital channels and networking, and the recreational drug MSM, the EM, late diagnosis, aging, inclusive society, okay? And the PrEP issues are all the challenges we are now facing, okay? Okay, this is clear player, but just give a clear player. But I want to recap here is the wider society, Don't forget those who are not interested but have competing interests, okay. Almost finished? Yes. From the perspective, I'm used to be a government officer, okay. I'm used to be a government officer, now retired, okay. In doing the so-called every year we have to write project submissions to ask for funding, project service development. We are facing the dilemma of allocation. Whether the money should be spent more on medical and health, housing, education, every welfare development. And this is a competing interest. This is somebody here. Okay, 5分事, okay. You see 5分事, okay. Okay, and then we have coming back to the medical and health is whether we spend more money on prevention and on treatment. Okay, in terms of treatment, this is treatment for rare disease, and the SMA issues. Is the treatment is in terms of $1 million for one patient, and this is for rare disease or common disease. Should we spend more money to better improve our diabetic service, and which disease? Okay, not mentioned, including AIDS and HIV. Okay, and treatment and rehabilitation, psychosocial well-being, the mental health issues. Okay, a large black hole. Right now, to attend more patient or versus spend more time in an individual versus health promotion, prevention versus research. These is all competing interests, and how to convince the budget holder and the public that the public money should allocate to a particular public services or policy. This is not only your difficulty. It's also my difficulty, okay, or when I was a government officer. Very difficult, this is something happens. This is illustrate. This is, 5 biscuit and 2 fish. 5 biscuit and 2 fish, you know that, okay? And we are competing in interest. Okay, whether it is wrestling or we join hand in hand, or we are, playing the tango. But I think we have to sit together and to better talk and communicate with each other. Okay, this is the last line. This is about the normalization. This is inclusive normalization that we cannot differentiate. You create a pattern, this type of pattern. Okay. It's very difficult. It's not difficult, but some people like to have this kind of pattern. It's a fully 全融合, fully inclusive. But some people, they like to remain their unique identity, segregate and create unique identity. Okay, well, which is the best? But we know that from the audience perspective, like you, do you like this pattern, or this pattern? Some people, they like this pattern. Some people, they like this pattern. Okay, it is very interesting. Let's think about it. What we are doing, what we should do. Okay, thank you.
So we now have the 10 minutes Q&A section. So because we overrun a bit, so maybe we can only have like a 1 to 2 questions. And 不過你哋可以一間coffee break 嘅時候 still have a lot of time to exchange。可以係啦。我而家有請埋Professor Zhong 係啦上嚟。Okay, thank you。好，隨便坐。你哋兩個可以自己講一日，我覺得都會好好聽。係好，is there any questions online on the floor? Okay, if no questions, and then I will have you to go ahead to answer the challenge questions that Professor Roger been asking. You know, how would addressing the social determinants look like in the context of Hong Kong? You know, your role as the chairperson of ACA. You know, how will you see? Yeah, how will you?
Well,
that's a big question. Sorry.
I'm sorry to put you on the spot.
Okay, it's a very big question. I think as a chairperson, as I said, my strategies is the so-called social determinant, and I'm going to use the platform of Advisory Council on AIDS, and maybe sometime where I may invite Professor Jones to make a presentations in the Advisory Council on AIDS meeting, and to enlighten the members of Advisory Council on AIDS, which is very specific. Okay, we can do it without difficulty. Okay, Lisa, what do you think? Yes, to enlighten the members the issues of social determinant. This is one thing. The other thing is I still believe that we have to engage a wider community engagement, and we create some kind of platform or even meetings to engage some of the so-called people who have interest but not interested. Okay. And to exchange with each other, and But on that, we as workers, we have working in this field for many years, but we have to also be humble. Myself, to listen to the people who have interest but not interested. What they actually think. What are their concerns? What are their concerns? And this is a true exchange of ideas. And it's possible we can engage them to address many of at least some of the social determinant, as Roger proposed it in his talk. Okay. Okay.
Cool. Thank you.
Oh, you're welcome. Okay. I wish I can address a little bit of your questions. Okay.
I think we can all take more time to deliberate on how we can address social determinants of health. Yeah, but that was a good idea, and I accept your invitation.
Okay, well,
Excuse, hello? Yeah, I would actually, I've been thinking, because you put together health equity and the HIV, I look at the number there. I wonder if has there been any study on the socioeconomic status of those people living with HIV at all? Is there any? Because I think in Hong Kong, people have actually access to HIV care, like in the center in County Bay, or so has there been any study on these people living with HIV, and has there been any? Have they been denied access at all? All right, or apart from the social stigma or any other things? Thank you.
Okay.
Do you know? Have you collected SES indicator in your studies?
Okay, I may pass the questions to Bonnie. Do you have any idea whether we are collecting this data?
Thank you for the question. I don't think currently we look at these social, the income and stuff, But usually what data that we're collecting would be the route of transmission, that route of acquisition of HIV. And, but based on my frontline clinical experience, we are seeing people from all walks of life. And, you know, from those who are very marginalized, jobless, homeless people, to those who are so highly educated, getting more degrees than, you know, a lot of us do, and making a very, you know, very economically productive. So I guess it's, well, as for, you know, Roger mentioned, here in Hong Kong, we are offering, you know, no one should be denied of medical care because of just financial constraints. So this is what we are doing. We're offering, you know, a lot of support to our clients who can't, you know, pay for the medical fee. And for those who even can't support the transport fee to our center, they are well taken care of by all, you know, the supports from NGOs, the AIDS concern delivery service, and our social worker has been on site providing support to them, facilitating the access to care. So, but it would be interesting, actually. I actually learned a lot from Roger's talk, and I do believe that there are room for collaborations to see how we can tackle it more deeply. How, instead of just offering a longer broom to those who are marginalized, how we're going to just remove the fences. Well, this is, you know, a really nice picture. I usually come across the baseball one. But I'm going to use the new one in my future, you know, sharing.
Sure.
But I definitely, you know, will approach you and see how we're going to, you know, look at this in a more scientific way to make things that's publishable, quotable, that we can use to convince the policymaker to help us, you know, provide equality of care and equity and things to people who are in need. So that's my sharing.
Just add on your question, like I myself, like, is more on qualitative research, like so like I can provide you like kind of like figures, but like through my own research and also like my connection with AIDS Concern and also other NGOs in Hong Kong, there definitely like a lot of like disadvantages, you know, for certain group of like people, especially vulnerable groups of people, in terms of the way how they can actually access to medical or social services. For example, like LGBT, especially older LGBT, and also female sex workers or sex workers, male sex workers, and other like vulnerable groups. Like, yeah, but I can't provide you like, you know, sort of like figures, but I'm sure, and I'm sure like, you know, later like AIDS Concern or maybe some other like NGO people, they may share with you more like the qualitative data or like narratives to let you know a bit more about that. Yeah, so I just want to add on that.
Just to follow up, I think it's a very good idea to do a more systematic, structured, empirical study on who are these people in terms of their socioeconomic background and education attainment, etc. I think that would be a meaningful thing to go forward. Yeah.
And I'd like to actually supplement, because from our end, we are seeing a biased sample, because we're seeing clients who are linked to care. It's more often a time that we don't have access to those who fail to come to us. Exactly. Yeah. So it needs to be some concerted effort in the community to see, you know, who these people are who failed to be linked to care. Mm-hmm. So this is the thing I want to supplement.
Yeah.
So I think we can have like one more questions.
Thank you for the presentation. Just a short question regarding to the social determinants of health. Yeah. What do you think about the PrEP adoption in Hong Kong? How could we to reduce the effect of social determinants of health when we would like to adopt the PrEP adoption in Hong Kong, especially for the young gay community, which can afford the private PrEP in Hong Kong?
That's a good question. Okay, maybe I'll supplement.
Yeah. Okay. Me? Okay. PrEP? Talking about PrEP. Okay. Okay. Yes. Okay. And okay. Put it this way. For the time being, we have We have the Special Preventive Program. They have conducted researches or commissions. They have researchers on the utilization of PrEP among the MSM in Hong Kong, and I think we have some figures on it, and but not shared in my talk. And most of the people who adopt PrEP in Hong Kong, they acquire the PrEP from Thailand, the PrEP tourists, and some of them acquire from the internet, and some acquire the PrEP from the local service provider, including NGO and including the private service provider. Okay, this is the group, but overall, the percentage of MSM who use PrEP is not very high in terms of not very high. It is, but one of the important observations in our survey is that when they acquire, say for people who acquire the PrEP from Thailand, when they come back to Hong Kong, the adherence to the PrEP protocol, okay, and to secure the appropriate PrEP as prevention for HIV, acquisition and HIV prevention is not very good in terms of they may not take PrEP as we recommended. They do not attend for the regular STI screening. They do not attend for the regular checking for HIV, and this is some of the observation we have. But the key questions, I think, at the back of many people's mind, which is whether PrEP should be provided by through the public medical public services. This is your question. This is the key, the central key questions. I have said, okay, we have competing interest. We have not you and we are required to convince not only the government officer, not only the budget holder, not only boss, okay, not only the chief executive, but we have also to convince the community as a whole, the local community, local people, the common people. We have to tell them, convince them to support such a policy of providing PrEP, okay, through the public medical system. This is I use the term is the social marketing of the whole HIV/AIDS program. This is one of the area within this HIV/AIDS program. This is the social marketing. How we can do that? Okay, we have a good story for condom social marketing. To start with, at those years, promote condom, well, which is not a good idea. From the back of mind of many of the lay people. Okay, you are promoting condom. Are you promoting promiscuity? Okay, this is their mind. Okay, but after so many years work, so many strategy. Okay, now it is not the sort of we have a very easy to promote condom without giving the label of promoting promiscuity. Okay, this is the story of the condom social marketing. But in terms of this HIV/AIDS program, okay, we have to think how to convince not only the budget holder, the government officer, but also the community people as a whole. Okay, this is the answer I put up. Okay, you may ask, do you have any very concrete strategy? The answer, unfortunately, I don't have a specific and good solution. But this is why I said we have to engage the people who have the risk, engage the people who have interest but not interested, or have competing interests. This is the messages. hidden in this short statements. Okay. Okay.
I think this is very good. I just want to supplement a little
Thank
bit.
you. Thank you.
No, I think this is great, and I think I just want to remind people that when it comes down to public policy making, there are always different ethical principles that underpin policy making, and usually when it comes down to public health, it is always the utilitarian approach, the utilitarian argument that really trumps the other ones. Because you know, when it comes down to public resources, then it is the interest of all the people in the society, not only you know, a few individuals. So you know, you have to strike that utilitarian balance, meaning that we need to prove that, you know, if PrEP is the one that we're concerned about, we need to prove that PrEP is not only cost effective, but also very effective, right? Effective and cost effective, and also it can maximize the benefits, minimize the harms better than other alternative strategies. So I think that would be, you know, if we can prove that and show evidence on that, that would be very helpful. If we're talking about that particular intervention.
Okay.
Yeah.
Thank you. Okay. And any
Thank you, thank you. So, so I look forward. Maybe, you know, AIDS Concern and Dr. Hall and Professor Roger, we can do a research, you know, together with the community. You know, like to do. I do agree that, you know, like collecting evidence to prove the case, and also to continue to do different educations, helping people to understand more from the cultural perspective. You know, people always think like what you said is a condom is like a taboo, you know, like many years ago, but we distribute that. So maybe it will happen, you know, like in years to come, but it's still like how we build the foundation, do the education, do the research. Okay, thank you so much. Thank you so much. Okay, 我哋會影張合照先啊，好冇啊 ？Okay, so we will take a group photo together.好，我哋而家有個小休，幾多分鐘而家？五分鐘啦，有個少少嘅 coffee break 俾大家 stretch 下，係啦。So we'll have a 5 minutes coffee break for you to go to the bathroom, do some stretching. We'll see you in 5 minutes.
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right, I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right, I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say everything is fine. But then again, they also say things like, we're loving this. And great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer,
Hello，
so
大
good.
家可以，我哋下一節可以開始㗎啦。咁麻煩大家可以坐翻低。係，our next session's about to start, so if you can take a seat, we can begin. Take a seat, please. Hi, take a seat.
This will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
Hello. Hello.
At Gilead,
大家可以麻
to
煩
delivering person-centric
Hello?
advances in HIV research for more than 35 years. Our latest innovation
可以麻煩大家坐翻低，
concept
我
of
哋下一個
drug resistance.
session 開始㗎啦。
Resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to
Hi
others who
everyone,
also
welcome back. We're going to start our next sections on mental health soon, so please be seated. Okay, welcome back everyone. So we're going to start our first conference sections. The theme of this part is the interconnections of mental well-being and sexual health. So I would like to introduce our moderator of this panel, and then she will help us to introduce our speaker of this panel. So Amy is the assistant manager of PLHIV team at AIDS Concern. She is a public health practitioner and a social worker with over 8 years of experience working in NGO organizations, doing drug prevention, sexuality education, as well as the LGBTQ plus counseling. So welcome, Amy. And then the title of this section is very interesting because we are talking about bringing in the concept of quality of life. So it's improving the quality of life of PLHIV from the meso and macro perspective. So welcome, Amy, on board. Yeah.
So to kick off our first session, the interconnections and well-being of mental health and sexual health, I'm honored to invite Dr. Crystal Lee and Odile Thiang to the panel discussion to share their expertise on improving the quality of life of PLHIV from the meso and macro perspective. So Dr. Crystal Lee and Odile. So Dr. Lee is a specialist psychiatrist and a fellow in community medicine. Prior to her psychiatric training, she focuses on HIV prevention and surveillance in the Department of Health. And on community basis, HIV epidemiology studies in the Chinese University of Hong Kong. Currently, she is the member of the Medical Advisory Panel for AIDS Concern, and she's providing consultations in the Queen Mary Hospital and the Integrated Treatment Center. Dr. Lee published an article last year looking into the intersections between mental health, substance use, and sexuality, and the study focuses on the recovery process of HIV-infected MSM with history of chemsex. And Odile is a very experienced pediatric nurse practitioner with over a decade of hands-on experience in Toronto and Hong Kong. Odile is a teaching fellow at the Hong Kong Polytechnic University and an honorary nurse consultant at the Hong Kong Children's Hospital. She has robust experience in clinical care, quality improvement initiatives in healthcare, and mental health stigma reduction education. Her commitment to serving marginalized community lead her to work with survivors of sexual violence and domestic violence and vulnerable LGBTQ+ youth. As the lead clinical advisor on anti-stigma and training at Mind Hong Kong, Odile actively advocates for affirming and safe mental health care for LGBTQ+ communities. Introduce myself again, I'm Amy. I'm the assistant manager for the PLHIV support team. And from my work experience, I've encountered people living with HIV of diverse backgrounds, age, and gender identity and sexuality, from newly diagnosed to people living with HIV for decades. The psychological distress is common among newly diagnosed and people living with HIV for over a period of time. They have an increased risk of mental health conditions, so I'm honored to be able to learn from two experts in the mental health field. So I think I would like to ask Dr. Lee first. What is your experience in working with PLHIV? What is their journey look like in the medical system and community? And are there any common challenges they are facing?
Thank you, Amy, and thank you, AIDS Concern, for the very kind invitation. So, what's my experience with working with PLHIV? I need to put up some slides to guide myself talking. So, I've been in the field for many, many years. My first experience was with PLHIV, was with patients with hemophilia. I'm not sure if any of you have come across patients with hemophilia and HIV in your practice. It's been, I was counting, 40 years since they contracted HIV in Hong Kong. And at that time, 20 years later, when I first joined the SPP, I met most of them, I think 20-something, if I remember correctly. As a very junior medical doctor, I was talking to them, and they told me all the stories, all the discrimination, all the mental problems, all the physical disabilities they have been facing. And I was very touched by each of their story. I think that what they have gone through is very unique. It's like an iatrogenic infection, and at that time it was a fatal illness. It was a fatal disease. Everyone was like very hopeless, and they were struggling with life, their families, their work. So that was my very first impression of HIV infection. I mean, people with HIV. I don't know if any of them are still here today. It's been 20 years, it's been 40 years. I still remember most of them, their stories, and I was very touched by them. And I was very struck at that time. And that was what Dr. Ho was mentioning, the ex gratia payment they have been receiving. And we actually, from that study, we increased like more financial support to them, and we coordinated all the medical services they have to go through, from orthopedics, medical, and then liver problem, hepatitis C, and then HIV. So many problems, and then we try to delink the problems they get through services, and to smoothen the coordinated care they were experiencing. So that was my very first impression of mental health, HIV. They were full of anger. They were so pessimistic about their future at that time. And then the second experience of pediatric HIV I had was the the MSM, the epidemic that started 20 years ago. So again, I interviewed some of the patients, how they acquired HIV through parties. At that time, ecstasy, ecstasy. Just thought it was a party thing, happy, recreational. And then they didn't think about having HIV at that time. And then 20 years later, of course, is the chemsex Dr. Ho has mentioned. The patients that I've been seeing are suffering from meth addiction, meth dependence, depression, psychotic disorder. And many of them thought they should be quitting, but it's so difficult. And they have gone through like different stages in abstaining, relapsing, abstaining again. And of course, struggling with whether I need to tell who is supportive, who may not like me at all. And then just 2 words about the last one is the female sex worker. Again, Dr. Ho mentioned, so I mentioned it again. I was working with another NGO, and then we detected some HIV infection in female sex worker locally 2 years ago during the COVID. I just want to mention one point is that after we told them, oh, this is HIV, and then we took blood, it's confirmed, they disappeared from the NGO. We refer them to the clinical service. They were there, but then we became disconnected from the community. Perhaps that highlighted the stigma, the self-stigma. They don't want to be like known to others, get in touch with others. I don't want to talk about HIV because the NGO, one or two staff would know about their status, and they get disconnected. So perhaps that's one story that reflects the self-stigmatization that I saw from the female sex worker infections just 2 years ago in Hong Kong.
Yeah, that's very true. I think from our experience, we have trouble maintaining contact with newly diagnosed positive case from outreach, like mobile testing. Oftentimes, they gave us like a fake number, and then we wouldn't be able to contact them. Or like after a few contacts, they blocked us. And then actually sometime like maybe half a year later, we received a text from the phone, and then like they came back asking like, I got some symptoms, and like how do I access healthcare and stuff like that. So that does reflect the self-stigma or the self-isolation and mental health condition, like when they newly diagnosed. Yeah. So I think, Odile, you have more experience working with LGBTQ+ folks. So I want to hear your insight on, is there any like challenges they face that is like a barrier to their sexual well-being?
Yeah, so I'll segue from your talk about stigma and continue it. Stigma is everything. When we're talking about health in general and sexual health, I think oftentimes we don't associate stigma. We just think about it as like, this is just a health problem. But stigma is everything. Stigma is going to impact, from a macro level, it's going to impact policies. It's going to impact financial distribution. We were talking about that earlier this morning. And on an individual level, it impacts how a person actually gets to explore their sexual health. So individuals within the LGBTQ community don't actually get to naturally explore their sexual health and sexual preferences in a healthy way, meaning that throughout high school, they generally have to stay closeted, either because of bullying, they have to stay closeted from their family members, so they don't have these conversations at home either. And so what happens is when we have to go into the shadows, that's when issues arise, right? You might be engaging in chemical sex, like we talked about this morning and just now, which is a much more risky behavior. Because you don't have like the interactions that other cisgendered hetero youth will have in high school. You don't get to like go to a guy or a girl and say like I kind of like you, start dating, doing like those natural progressions, right? It has to go underground. The other issue as well is we are not really good here in Hong Kong at sex education to start with. And so even if they do get some information on sex education, they get it from a hetero perspective. And so individuals who are not engaging in heterosex don't actually understand what are their risks and what do they need to do to keep themselves safe, because we're talking from a very, very specific lens, which does not speak to them. I'm just going to go back really quickly to the chemsex. A lot of the issues with chemsex is the community that is engaged in chemsex, they're engaging in it because of kind of underlying anxieties, underlying stigma and self-stigma, using substances to either ease anxieties around these interactions because they don't get to have them in like a normal setting on a day-to-day basis. And so that's sort of, it comes back to the stigma, the self-stigma, the homophobia, internalized homophobia, and other kind of communication that they're getting from their environment. So I think it really, it's everything. And one of the reasons that got me on sort of my allyship journey was, it was in my first 2 weeks of becoming a sexual assault nurse examiner, and I was called in at midnight. I got a page, and the dispatcher said, you need to come in. There is a young man here wanting to talk about a sexual assault. And I thought, oh my God, it's a guy. Most of my patients during my month-long training were all women. I had lots of patients, but they were all women. We did have lots of training about LGBTQ concerns, so I had to kind of dig deep and kind of think about, okay, what do I need to do if it's a guy? Okay, it's the same thing, but what have you. And when I got there, we started chatting. We talked about his interaction. And what happened to this young man is something that I've heard over and over again. I've heard it from my own friends. He, got this date online, went to a neighborhood that he's unfamiliar with because, God forbid, should he be seen in his own neighborhood with another person, another guy. The person that he met there was not who he represented online, and then he was assaulted, right? So when you're not able to explore your sexuality in a healthy and natural way, you have to kind of do it in the dark, do it in the shadows. We were able to connect because I had to talk to him kind of as a girl about, safety and dating. But when you're in the shadows, you don't get to have those conversations with your friends. I had those conversations with my girlfriends, like, you know, what do you do when you go on a date? What are like precautions that you take? You make sure you have extra cash so that you can get out of there. Or a girlfriend would tell me, do not meet this guy, it sounds really sketchy. But they don't get to do that. And so we have to be really cognizant of really working on the community, really working on the population at large and reducing the stigma both of mental health and of sexually transmitted infections and LGBTQ identities.
Yeah, I think the lack of inclusion, diversity of no matter gender or sexuality, and also maybe like neurodivergent like inclusiveness is causing people to not be able to say what they are experiencing. They kept closeted, and like the risk of turning to substance use would be high, and like having other mental health condition would be high. Yeah, so we talk quite a bit about interpersonal and self-stigma. Dr. Lee, I wonder, like, if PLHIV or LGBTQ plus folks are facing some structural stigma coming from cultural, social, and legal factor, and on a macro level, how can we improve the quality of life of PLHIV folks?
Very difficult questions. Anyway, so I was thinking, all the self-stigma, discrimination, closeted. So whether you're just being not the majority in the group because you are like having different like non-heterosexual, or having an HIV infection, so that actually put on much more extra stress on your psychological like demand. So I just listed out some of the issues that I thought of for PLHIV, for example. So the issue of discrimination, and I remember Amy also like told me, oh, PLHIV would have problems getting into elderly home. Say, the elderly home may like check, their medical history, and then, infection, I don't know, maybe Amy can share a little bit more. But then they just go through all the like social services, medical services. They always have to decide whether I should like reveal my HIV or whether I should like conceal. So that put an extra stress to it, because like this with you every 24 hours every day for every day in a year, you have to think about whether you should tell people or you should conceal. I think that's a lot of stress for anyone. And apart from like overt discrimination, I think bad attitudes, it's one of a very important sort of stress as well. So think about, for me, like死肥妹，即係你好醜樣 ，OK？ So all these kind of bad attitudes， 你咁肥行開啲 ，OK？ I mean, if that refers to your sexuality or HIV, say, I think that would be really sad, especially if I were really young and I'm not resilient enough and I'm not having good support from my friends. That would be like really stressful. Other worries about future, right? I'm alone, I don't have a partner, I'm HIV, I'm not lovable. Like, no one would love me. I worry about transmitting to others. So worries about future. I mean, I also worry about my future. I mean that having HIV or being not a majority of the population, I think that would really create extra worries for them. And from my experiences working with PLHIV, I think some of them would have a lot of stigmas and different meanings attached with HIV, the virus. Many of them would have shame, like feel shame and guilty. And the core value we talk about is that I'm not lovable, no one will love me. I think that if having that concept for the rest of your life is so distressing and is so dark. So I think all these would create lots of demands psychologically for PLHIV. And if you are not being resourceful enough, you are not resilient, you don't have a good supporting network, you don't accept yourself having the virus, you don't accept yourself being gay, and you don't know how to solve them. You don't know how to solve. I don't have like place to live. I don't seek Amy's advice. I don't go out to ask a district councillor for help. So that would be like really stressful, having a stressful situation that may really hamper their quality of life and mental health. But of course, there are situations or there are individuals who are really resilient, having good problem solving, self-acceptance. They may turn that around, and they would like internalize that, oh, it's okay, I understand why people are doing this, I still have many good qualities, I still have many good friends, and they can move on. So I think that's the issues that they were facing, and if they are not being resourceful, that would create lots of mental health stress for them. I should go on, yeah. So what can be done to improve the quality? So I searched like AI, and then I was thinking how to change the social environment, being more supportive and less discriminating. So I think that's a very good model for me to talk about how we make change, improve acceptance. So that's the social change model that talks about individuals, group values, and societal values. So if each of us can embrace the compassion and then find some groups to collaborate with common purpose, and through that interaction, we can perhaps bring about change in the society for the common good. So, of course, everyone in different positions in the society, I think they have different methods to work with the people around them. Maybe in your school network, your friends, your office, in your reaching out to other groups. So all these would make changes in the society. I was searching that what's actually acceptance, what should we do? It was back in, again, many old days. I mean, old days, 23 years ago, we already set a paper by the ACA at that time that what's actually promoting acceptance. They have listed out all the principles, things should be done, but two of the principles are listed here is that non-discrimination is not limited to anti-discrimination, but also with positive qualities of equality that we talked about this morning, compassion and mutual respect, and acceptance of whatever people entails a change of attitude, cultural norms and values. So I think that would be that can guide we go forward. What should we be going through? And Dr. Ho mentioned the ACA. Of course, this is one important chapter in the strategic area that we should work on the policy, we should build our capacity, we hopefully can change some guidelines, regulations, we go on to have media campaign. These are some of the things that we can work through in a more macro perspective. Yeah, so that's how I think being individual or affecting your groups and we can make a change in a society.
Yes, that's very true. To promote inclusion, diversity, and doing anti-stigma education is very important. And I believe our small efforts as an individual in the system, and then slowly we can build bigger changes and a better environment for people of different diversity. So we have mentioned quite a bit of concept of intersectional. Sorry, I'm tricking up on this word. Yeah, intersectionality. Yeah, that's a very tricky word. Yeah. So in the context of PLHIV and LGBTQ+ folks, it basically means there is a complex cumulative way in which the effect of multiple forms of discrimination and oppression would overlap and intersect to create unique dynamics and inequalities. For example, an elderly gay person living with HIV, living in an elderly care home, with their adult child all away overseas, never knowing his own status. Or a 30-year-old woman newly arrived in Hong Kong, needing to disclose her HIV status to her husband because they're planning to have a child. It's multiple factor, multiple identity, all overlapping and really complex situation. And everyone is experiencing their unique experience and oppression. Yeah. So my question for Odile is, in response to like the intersectionality, I got that right, how could we respond on an organizational level?
So I think the most important thing is to remember and understand that no community is a monolith. And the LGBTQ community is not a monolith. Even within the alphabet salad of LGBTQ, you have almost like hierarchies of privilege and hierarchies of marginalization. So, for instance, we have gay men who, just by the virtue of being men, have a certain amount of privilege, and that kind of translates into the general, like how the general population kind of sees them. On the other end of the spectrum, we have transgendered women, and particularly if these transgendered women are associated with an ethnic minority. And so you have kind of layers and layers and layers of both marginalization as well as privilege in certain cases. So understanding that is really important, which also means that it's really important for us, if we're talking from an individual level, to one, do a really good psychosocial assessment of that person to understand what are the stressors that are impacting their day-to-day lives, and not just assuming what they are. From a more structural perspective, I think it's really important for us to never, ever, ever embark on doing anything towards a community without having the community say, fully embedded in it. So nothing about them without them. I have seen quite often very well-meaning people in privileged positions that are not within the community who want to be allies and who want to support, embark on kind of, strategy or kind of projects, but never actually asking for the needs of the community. And when we're asking for the needs of the community, we have to make sure that we're not just asking like the gay guy that's like around, but we're asking like a wide variety of individuals so that you're getting those layered responses and layered feedbacks about the services that you're about to provide, or the changes that you're trying to make. The other thing that is really important is to always have a trauma-informed approach when we are, either dealing with an individual on an individual level or on a more structural level. And a trauma-informed approach just means that we are understanding that there are, because of all these intersectionalities and because of all these layers of either of marginalization, people are coming in with their own sets of either small t or big T trauma associated with their different multiple identities. So, just keeping that in mind and not just painting everybody with like one broad brush stroke and making assumptions. So really important, getting the perspectives of the people that we're trying to support.
Yeah, getting the consumer perspective, never assuming, and like creating a safe and inclusive environment for the people to be themselves, like in like a safe space and in the community. Yeah, so it was a great discussion. Too bad we have a limited time. So I think just to wrap up, is there any take-home message for the audience?
Already prepared. And it's a summary of what we have talked about already, right? HIV is not a priority health topic. Dr. Ho mentioned that. I think that's a very important part, that how we can strike among different competing challenges. And specifically for HIV, or like sexual mind, or I think more for HIV, that patients are highly invisible. I think that's a very important part of the issue. I mean, for SMA, people can go to 最激係嘛？7點咩話？ Dongjiang Saimong, yes. You can go to Dongjiang Saimong and then talk about, oh, it's a very sad story. We don't have money, and then people will donate. And remember, in the past, the newspaper that have already been like disappeared, they also have some donation, Songlun, and people can make their stories out and then ask for compassion from people in the media publicly. But for HIV, I think that's like a different story. It's very difficult for them to talk about their difficulties public. I hope we can, like, if I talk about that thing, if we have some people who can like cope with that it's okay, it's infection, be a very strong, resilient, self-acceptance, patients can come out and talk about their difficulties for the community, and that would help us compete for these resources with compassion, because we thought people should have compassion, right? And each of us, before we do that, perhaps we can all be the agent for change in various groups, as I've mentioned, maybe in your social network, your office, your nurses, your staff. I think from what you practice and believe, you can cultivate and influence change in the people around you. And embrace compassion and mutual respect as really the most fundamental value of your professionalism and the wider society as well. And then with that, I hope we can make some change in the community.
So I'm going to give my kind of final thoughts from a cisgendered hetero woman perspective. What I have seen from working with the LGBTQ+ community is an immense level of resilience. Not weakness, not, I mean, there's struggle, but an immense amount of resilience. So from my perspective, they don't need allies to do anything for them. They need us to walk alongside them and help with our privileged position to elevate their voices and allow them to speak for themselves.
So thank you, Dr. Lee and Odile. So I think we'll wrap up this session and we'll join Dr. Gordon Wong after together for an Q&A session. Yep.
Thank you, Dr. Lee, Amy, and Odile. Okay, so we'll now invite our next speaker, Dr. Gordon Wong. He is a specialist in psychiatry and also the honorary clinical assistant professor in the Department of Psychiatry, Li Ka-shing Faculty of Medicine, the University of Hong Kong. So Dr. Wong will equip us with some tips in supporting the mental health of PLHIV in Hong Kong. Dr. Wong, please. Thank you.
Thank you very much for the introduction. I'm very honored to be here. Thank you very much. Thank you. So, do I press here? Or, oh, yes. So thank you very much. And I'm Gordon, and today I'll share with you some information and insights in mental health in people living with HIV. So there are three parts to my talk. The first part is people living with HIV and mental health problems. So people who do live with HIV, they do experience quite a few mental health problems. So people with HIV commonly have mental health problems, as I will talk about in a minute. And also, people who have mental health problems are at higher risk of acquiring HIV. So it's like a vicious cycle where people who have mental health problems, they get a higher risk of HIV, and then when they have HIV, they have a higher chance of mental health problems. So it's a cycle that doesn't seem to end. So as professionals, we have to do something to help these people who are experiencing challenges. And one of the challenges that people may experience is that LGBT people are often marginalized and often facing discrimination, and therefore that would in turn increase the risk of mental health problems as well. So it's like a perfect storm where all these factors, intersectionality, as Professor Lee has already mentioned, they really brood together and create a lot of mental health problems. So over time, over the spectrum of time, people who do have HIV, people who get infected with HIV, they may, at first, when they find out about the diagnosis, about the presence of virus in their body, they may experience adjustment problems, such as adjustment disorder due to newly diagnosed HIV infection. And over time, there could be a lot of anxiety, a lot of depression because of all these different stresses living with HIV. There may be like discrimination, marginalization. And over time, there could be shame, disgust. There may be self-stigma. And therefore, people isolate themselves. They don't want to tell anyone about their HIV infection. They isolate themselves from friends, from family, and they may feel very guilty or having contracted the virus. And I will talk about that in a case I will share in a minute. And over time, some people, on the other hand, on the other end of the spectrum, some people may feel that they have to do something to make themselves healthy, make themselves as healthy as possible so that the virus doesn't affect their daily life. So they may do as much as possible to stay healthy. They may exercise a lot. They may eat very healthily. They may take a lot of supplements. And because they want to stay so healthy, they may have a lot of health anxiety when they have the most minor physical problem. When they have a headache, they think, oh, is it HIV? When they have an itch on the skin, oh, they think, oh, is it HIV? So that could be the other end of the spectrum. And so there can also be substance abuse, substance misuse, or chemsex, because some people may think that, oh, now that I have HIV, it doesn't matter anymore. I can have as much sex as possible. So that could also lead to other problems, like such as superinfection, and also substance misuse problems like psychosis. So that can also lead to many other problems. And over time, because HIV directly infects brain cells, there can be cognitive problems such as memory impairment, language impairment, attention problems, and I'll talk about these in a minute. So in psychiatry or in mental health in general, we often devote our time in depression and suicide because suicide is like the ultimate outcome that we want to prevent. And in people living with HIV, it is actually very common to have depression. So 30 to 50% of people do experience depression, a major depressive episode, sometime after HIV infection. So one third to a half of people with HIV experience depression, and that is very common, so we have to actively look for it. And suicide is a symptom, a behavioral manifestation of depression. So, and in people living with HIV, there is a 9 times increased risk of suicide. So that is also something we have to look for. The risk factors of suicide include younger age, because people who are younger, they're often more vulnerable. They may not have the psychological or material resources to cope with the diagnosis, to cope with the problems associated with HIV. There can psychiatric illness, as I said, is very closely linked to HIV infection. Social isolation because of self-stigma, stigma from the society, that also increases the risk of suicide, and also exposure to some antiviral and antiretroviral medication that also can increase the risk of suicide. So we have to bear that in mind. Apart from depression and suicide, there can be other mental health issues related to HIV as well. So one issue is mania. Mania is the opposite of depression. So a lot of people have a misunderstanding regarding mania. So in mania, in Chinese, 狂躁. And 狂躁, a lot of people think that 狂躁is irritability, is the tendency to throw temper. But the medical definition of mania is actually to have at least 4 days of sustained elated mood with a decreased need for sleep. And and irritability is only one symptom of mania. So we have to bear that in mind, the medical definition of mania in mind. So mania can occur as a part of HIV psychosis, or it can also be a side effect of a retroviral medication. So that is something to bear in mind as well. Another manifestation, mental health issue, is anxiety. So people who do live with HIV, they can experience a lot of different anxieties. Biologically, the anxiety could be a generalized anxiety disorder, meaning that the person is anxious like all day, every day, most of the time, like being anxious for no reason. There can be panic disorder, which is an intense bout of anxiety that seems to come out from nowhere, generally lasting about 20 minutes. There can be post-traumatic stress disorder and obsessive-compulsive disorder, and that is also classified as anxiety. For HIV infection, because the HIV virus affects basically the whole body, so there could be chronic pain as well, and studies suggest that 80% of people living with HIV experience chronic pain. And when you live with chronic pain, people just take medication to relieve the pain, and that can lead to that can be a risk factor for substance misuse. Another mental health issue that may manifest itself is delirium. Delirium is an acute confusional state, which is fluctuating. It fluctuates like from hours to days, so the manifestation of delirium can change within hours. So up to 30% of AIDS patients have delirium, so it is quite common as well. And this delirium, this acute confusional state, can be caused directly by the virus. It can be caused by secondary infections in the brain, that may be due to tumors or substance withdrawal when people take substances, such as alcohol or some other anxiety medication. If they stopped cold turkey, then that may cause withdrawals, which may cause delirium. And another issue is psychosis. So that can be a feature in early HIV-associated dementia. And also, that can also be caused by substance use as well. I remember a case where when I worked in the public hospital, there was this 21-year-old guy who was admitted for psychosis. So he lives with his family members and also the boyfriend in the same bedroom. So the family is very progressive. And so he was admitted to the hospital because of abnormal behavior, not sleeping, trashing the flat, and he was admitted to the hospital. And so it was known that the person, this 21-year-old guy, had HIV. So at that time, I thought it was HIV psychosis. And then I gave him medication to treat the psychosis, and then his symptoms quickly subsided over like a day or two. And then so I let him go, let him be discharged from the hospital, and then some days later, the urine toxicology results showed that there was amphetamine in the urine. So actually it was chemsex causing the psychosis, but he didn't tell us at all. And because urine toxicology results takes quite a few days to arrive, like a week to arrive, so by the time the results arrived, he was already discharged. So that was quite a memorable case for me. So next, I would like to talk about HIV-associated neurocognitive disorder, which is also a manifestation of HIV. So HIV virus actually enters the central nervous system very, very soon after the first infection, after the primary infection, and then it stays in the brain. So the brain cells are directly infected, and it also causes neuronal loss. So that's why there is neurocognitive symptoms in HIV, people living with HIV. So it is actually quite common. So 30% of people who have HIV-associated neurocognitive disorder, these neurocognitive symptoms are the first complaint, the first presenting complaint. So they go to the doctor complaining of symptoms that are not, but that are very general, and it is actually the first symptom that that is manifest in an HIV infection. So 30% of the people with HIV go to the doctor for the first time because of these neurocognitive symptoms. So it is quite a big proportion. And these symptoms are often very general, so it can be hard for the doctor to decide that these symptoms are actually caused by HIV. And then as time goes on, 70 to 80% of people living with HIV can develop some kind of a neurocognitive disorder. And at postmortem, 90% will have some changes in the brain. So it is quite a big issue. So when I say that 30% of the people first present with a neuropsychiatric symptom, neurocognitive symptom, so these symptoms include headache, altered peripheral sensation, leg weakness, and also seizures. So when someone goes to the doctor complaining of leg weakness or altered peripheral sensation, the doctor is not going to think about HIV as the first reason for these symptoms. And yet 30% of the people present to the doctor with these symptoms. 30% of the people living with HIV first present to the doctor with these symptoms. So I think this can be quite alarming as well. So as time progresses, there can be some neurocognitive symptoms such as cognitive slowing. They may think slower, they may be more forgetful, they may be more absent-minded, motor slowing, their actions may be slower as well. There can be poor coordination. They find that, they have tremors when they hold chopsticks, or when they hold a glass of water, they may find themselves having tremors, the water shaking. So they may also visit a doctor for these symptoms, and the doctor is unlikely to come up with HIV as the first differential diagnosis. And because these HIV symptoms is hard to pick up, and therefore with time it progresses to dementia-like symptoms such as cognitive symptoms, difficulty in performing daily tasks, difficulty in retaining information, learning information. They may find themselves forgetful. They may find themselves difficult to find words to express themselves. They may find it hard to read and write, misplace items. They may even get lost in the neighborhood. They may even have, in severe cases, hallucinations, delusions. There can be motor symptoms, movement symptoms. There can be affective symptoms, which means mood symptoms as well, such as depression, agitation, disinhibition, apathy. So there can be a lot of different symptoms. So HIV causes a lot of different psychiatric symptoms, and we really, really have to look out for these. So I've so far talked about the biological symptoms, but there are a lot of different psychological and social challenges of HIV as well. So for psychological challenges, there can be worries of discrimination, which we talked about just now, a lot of self-stigma, self-blame. There can be a lot of guilt as well. So I encountered one person who blamed himself for getting HIV, blamed himself a lot. He said he's always been careful, but there was one time in the gay sauna, he just let his guard slip, and then he got HIV, and he felt very sad, very guilty about that. And with all this background of discrimination, stigma, self-blame, that the person is understandably feeling hopeless, feeling helpless, and because of worries of this discrimination, they don't want to seek help, which I will talk about in a minute too. So when they don't seek help, and they feel helpless, they feel hopeless, and then the person may feel very depressed and suicidal. At the other end of the spectrum, again, there can be excessive health concerns as well. So I remember one case, not HIV, but HPV. So someone developed a tongue ulcer, and he basically was so convinced that he had too much oral sex when he was young, and therefore he had tongue cancer as a result of HPV infection. So that's the other end of that's excessive health concerns. So another issue, another psychological issue, another mental health challenge that people living with HIV may face is that because of their mental health, poor mental health in general, like they may have a lot of depression, anxiety, shame, guilt, they may find that it's hard to seek treatment. They may find it hard to adhere to the treatment even if they seek it. They may feel that, oh, there's no hope anyway, why am I taking pills? I might just as well let the disease progress. Some people may think that, so that could be another challenge as well. Apart from psychological challenges, there can be a lot of social challenges. So we talked about a lot of stigma, discrimination, and that really affects help-seeking behavior. They may feel that they don't want to seek help, therefore they have no social support. They don't dare to tell anyone that they have HIV, therefore they isolate themselves from the society. And then another issue to think about is spousal acceptance. Is the spouse going to accept the HIV diagnosis? Because I remember one person who, I'll talk about that later in the case. So, and also there are other social challenges include barriers to treatment. A lot of people don't even know how to seek treatment. So you can't just go to any GP on the streets to get HIV treatment, and people don't know how to get it because there are specialized centers in Hong Kong to offer HIV treatment. People don't know how to access it, and the cost of treatment as well. HIV treatment can be very expensive if you choose to go private, and privacy concerns as well. Some people are very terrified of letting people know of their HIV diagnosis, and therefore the HIV treatment provided by the government is really good on privacy. So in the hospital authority system, like in the computer system, you can't see any record from the HIV clinic. So privacy is really a double-edged sword. So when I talked about the 21-year-old man earlier who had HIV, so we just had no idea he had HIV because he was treated in Kowloon Bay and the hospital authority could not access that record. So we just had no idea he had HIV initially, and then he said he had HIV, so if he doesn't tell us he has HIV, then we wouldn't know. And then so I remember another case who was admitted to the psychiatric ward. He was confused and didn't know what was happening, so he couldn't tell us he had HIV. He couldn't tell us he was on HIV medication, so naturally we didn't prescribe the HIV medication. A few days later, his mental state improved, and then he said he was on HIV medication, and then we were like, oh, okay, but the treatment was already interrupted by a few days. So this privacy has its pros and cons. And then because of time, I'll skip through these special points to know. So I've mentioned that. So some HIV medication do have psychiatric side effects as well, such as depression, anxiety, and mania. So we have to pay attention to the iatrogenic side effects as well. And for local studies of people living with HIV, so I will just very, very quickly go through these because of time. So there are several studies that I know of that looked at MSM adults that were recruited from a specialist HIV clinic. So they looked at different mental health factors that affected mood, anxiety, and general mental health in people living with HIV. So one study found that stigma really increased psychological distress. So stigma includes in-group stigma, meaning within the LGBT community, within the HIV community, there is a lot of stigma between the community members. There were also a lot of stigma, internalized stigma, and also stigma from outside the LGBT group as well. There is also zero status disclosure concerns, meaning they are really concerned about telling people that they have HIV. And also negative medication reminder is also a source of psychological distress. Negative medication reminder means that when they take medication every day, they are reminded of, oh, I have HIV, I am diseased, I am ill, I did something bad, leading to this HIV infection, blah, blah, blah. So it reminds them of something negative every day. Another study also revealed that HIV, in people living with HIV, mental health is negatively impacted by similar stressors. Another study looked at relationship, a long-term relationship, and mental health, and it found that having a positive love attitude, like relationship attitude, would have direct and indirect positive benefits on general mental health. So now I'd like to talk about the case I've been wanting to talk about. So it's a man in his 30s. So I actually encountered this man in Queen Elizabeth Hospital. And so I was asked to see this man because of, basically because of his refusal to see a doctor for HIV treatment. So he was found, I don't remember why he had some blood tests, but he had some blood tests in Queen Elizabeth Hospital, and he was found to have HIV several months ago, like 6-7 months ago. He was referred to the HIV clinic, but he refused to go. So I asked him why he didn't want to go. So he came up with various reasons. So he had low mood, he had a lot of anxiety, he had poor sleep, he ruminated about the HIV diagnosis, and he ruminated about, what am I going to do? What's my life going to be like? How am I going to tell my wife? So he had like a lot of mood issues, but he still but he refused to see a doctor for treatment. So even if Queen Elizabeth Hospital in the ward, they offered treatment to him, he refused. So that's why I was asked to see that guy. So I asked him, so have you really not told your wife? And he said, no, I haven't told your wife, but I haven't told my wife. But what about, what did you do if your wife wanted sex? And he said he made various excuses not to have sex with his wife because he didn't want to infect his wife. But then he didn't want to tell his wife either. And then one thing that really distressed him was that he knew that his excuses wouldn't last. It's been 6, 7 months already that he made excuses not to have sex with his wife. But the excuse is just, he's going to run out of excuses very soon. So that was really distressing for him that he had to tell his wife, and he didn't know what his wife would react. So that creates additional stresses. So there's biological stresses, there are psychological stresses, and social stresses contributing to poor mental health. For the biological stresses, HIV may cause psychiatric symptoms directly. The psychological factors, the self-stigma causing him to not tell his wife, and social reasons, sociological factors causing poor health. He worries about how his wife will react, how people will discriminate him, and therefore all these contributes to poor mental health in this gentleman. So the take-home message is that mental health problems are very common in people living with HIV, and we really have to have a holistic appreciation of the emotional state in these individuals. We have to actively look out for mental health problems, and when we do encounter someone with HIV, perhaps with mental health challenges as well, we have to remember that we have to be professional, non-judgmental, and respectful. After all, we are treating an individual. We are interacting with an individual, with a person, and therefore we just have to be non-judgmental and respectful. We have to be empathic, try to understand what that person's feeling. We have to try to understand why that person's feeling this way, why this person's acting this way, and understand the presenting behavior and the presenting mood state. And we can try to help by increasing social support, maybe peer support groups or various NGOs for counseling, and if needed, we can also consider referring to a psychiatrist for management of mood problems or mental health challenges. And with that, I thank you for your attention. Thank you.
Okay, thank you. Sorry that because we overrun a bit, so Dr. Wong may not be joining us for the Q&A section, but welcome. If you have any questions for Dr. Wong, you can email us, and then I will deliver it to Dr. Wong, and we'll get back to you later. But now we have 5 minutes Q&A sections, so we can talk with Dr. Crystal Lee, Odile, and Amy. Just come up on the stage. Yeah. 5 minutes. Yeah. 5 minutes 就嚇，大家好好珍惜時間啊！Anyone have any questions? Yes, you have.
We heard all the challenges that people living with HIV are facing, and it's quite daunting, especially their mental health challenges, as we just also heard from Dr. Wong. I wonder, what are the success stories, and what is it that people benefit from the most when it comes to overcoming their internalized stigma and their related health problems? How do people, I'm sure there are people who are able to live with it in a more positive way. So from your experience, what is it that helps people the most?
Thank you for the question. I think this is a very important perspective too, the success story of people living with HIV. A lot of times from my work experience and the experience of AIDS concern, the social support is the most important thing that they need. An environment that they can meet other people with similar experience but also different perspective. For example, we group people of newly diagnosed PLHIV and people living with HIV for a couple of years, maybe middle age or older or younger. When they interact with each other, they would learn from each other. Some people told, one of my clients told me, before they, previously they joined our service when they newly diagnosed, and they received counseling sessions from one of our previous workers. And he didn't join our peer group and workshop for a couple of years, but he recently came back to our regular monthly peer group and meeting people who are newly diagnosed, who are younger, with partner, without partner. They have a new perspective from them to kind of maybe reflect on their own value and what are the experience. And it did make some positive changes according to him. And we we enjoy empowering all of our clients and peers that we interact with. We would have educational anti-stigma workshop that would invite PLHIV to share their experience with university or health, students and health professionals. And those are different ways of them engaging back into the community to contribute back to the people who they wanted to assist in. Yeah.
I think services like social services, psychiatrists, psychologists, whatever service they get in touch with, gradually with the treatment that they needed. Maybe psychiatric medication, maybe counseling, motivation interview. I think all these treatments are very useful for some of the cases. The other point I want to make is that sometimes, no matter how much we work, the patient is not ready to receive service or not ready to change. I think one important point is that we don't lose our patients. We don't close our doors. We are always open, and we welcome them to come in, whatever they are ready. And sometimes, very sadly, we have to wait for crisis, I think. Say, for example, there were crises, they will get admitted, and then the doctors need to, you have no choice, we have to call your family. In certain situations, I think these are somehow the crisis will open a door to open the dialogue. And then they will find, oh, my mother is actually very supportive. She's so supportive of my sexuality, everything, no matter, just that if I'm happy and I'm healthy, she's happy with. So I've seen quite a number of cases who are like this, especially when they got admitted or they got to see the doctors. And then some of them actually, their internalized stigma got like opened up, and then they got support from the people they need.
If I can just add and like reinforce what both of you guys said, more so from like my experience in Toronto. Number one is finding community, whether that's within your own family or a community that you kind of reach out to. And the other one is finding meaning. So finding meaning in what you're doing and finding meaning in sort of what you've struggled with and not just struggled with, but are now kind of thriving with. That has been some of the patterns that I've seen.
Thank you. Thank you so much. Thank you. Thank you. So we are now entering the second part of our mental health discussions. For this part, we'll zoom in and dive deep to inquire the topic more on the sexualized drug use, or what we call chemsex. So I'm so excited to invite our first speaker, Dr. Raina Tang. So Dr. Raina Tang is an assistant professor at the Saw Swee Hock School of Public Health, National University of Singapore, and National University Health System, where he received his PhD. So his topic of today is to share reducing harm and enhancing well-being among people engaged in sexualized drugs. Welcome, Dr. Tang. Dr. Tang fly to Hong Kong. He's so busy. He's been like, oh, I got a conference, and then being moderator in one conference, and then come here, and then tomorrow he needs to go attend another conference. Thanks so much for your time coming to Hong Kong. Welcome. Thank you. Yeah.
Thanks so much. Thank you so much. So where do I start? Let's see. I think, firstly, I want to thank the organizers and thank Nida so much for also reaching out. I think it's a real privilege to be here. I wanted to, actually, what was being spoken about this morning resonates a lot with me on both a research as well as a personal level. And I think it's important to also tie in, why I'm doing this and to situate my work in my own personal story as well. So, for me, I was diagnosed with HIV 15 years ago. So I've been living with HIV for 15 years, and that was when I was 20 years old. And it was a result of sexualized drug use or chemsex, but also because of a lot of the internalized stigma around living with HIV. I only sought treatment about 2.5 years after I was diagnosed initially. And, I was also engaged in a very deep cycle of chemsex. And it ended when I was admitted into rehab when I was 24 years old. And I spent about 1.5 years in Thailand in rehab, because in Singapore, rehab means prison. So, I'm privileged enough not to go to prison in Singapore. But, I had the opportunity to do that in Thailand. And after coming out of it, I think we started to do more ground-up community work to try and support others in the same situation, because we just didn't find any resources for gay men, in this area back then. We had generic resources from the Institute of Mental Health in Singapore or mental health services, but we just didn't identify with any of the support groups there. And I think you would see maybe from my slides later that we came from a particular perspective, but I think throughout my research and my work, both in the community and based on personal experience, we're starting to learn that there are many different angles we can take for addressing chemsex or sexualized drug use. And I want to apologize. So I use a combination of AI and my own I wouldn't say limited, because I learned Chinese growing up. It's just that my command of the language is not very good. So, there might be some things that are maybe awkward phrasing or not so good phrasing. Please forgive me. So I think I'll focus on harm reduction for my talk today. I won't cover so much of this because other speakers have talked about the definition of chemsex. One thing that I will say is that in Asia, I think we still haven't really figured out a common definition. And I don't know whether we will ever have a common definition because it is so unique to different contexts. And one thing is that for Singapore we have certain combination of drugs, but for Hong Kong it might be slightly different based on drug supply chains, which differ from region to region. So being able to measure that across different regions is also problematic sometimes. I think I've seen some literature coming out of, let's say, I think Guangzhou, that talks about alcohol being part of chemsex or sexualized drug use. Technically, you could kind of label it as that, but we're not really talking about the same thing. So when we compare these things, it might be a little bit difficult. I think the purpose of this slide, and I'm going to breeze through some of them because I know we are also running short on time today, but this here shows that based on even just young key populations at risk of HIV, you're already seeing people start young, including myself, right? So at 18 to 25 years old in Singapore, we ran a cohort study. About 5% of people had already ever used crystal meth in that cohort. In Dhaka, Bangladesh, there's in a cohort of 18 to 24-year-olds, about 6.8% reported ever using meth. In New York, it's about 10%, and they reported engaging in sexualized drug use in the last 6 months. So you can see that I think for young key populations, this is an emerging issue of a potential concern. Even worse is that among non-MSM or non-gay populations like transgender women or sex workers who are at risk of the risk of HIV, other STIs associated with chemsex, we don't really know much about that. And the research that has been on trans women, for example, tends to be aggregated together with MSM. So we don't really have that much research focusing on some of these subpopulations that are also vulnerable due to intersectionality and so on. There was a qualitative synthesis, a review done by APCOM on sexualized drug use, including chemsex, and the motivations that they found, I guess, in this region for Asia don't differ too much from that in the studies of the US and the UK or in Europe. These revolve around, say, enhanced sexual pleasure, freedom and confidence to explore sexual fantasies, and I really like what Odile talked about in terms of the context that we are in, right? I think a lot of these are also a product of, a very stigmatized context that we have grown up in contexts where we are not allowed to be ourselves, where we want to find some form of liberation and emancipation. So I think that makes a lot of sense. And so, issues like pride and empowerment or even beauty and social power should be contextualized in some of these narratives and contexts that we are growing up in. There are other issues of around using it as a social and sexual lubricant. There's some context where there's a certain community identity and culture attached to being in a chemsex community or sexualized drug use community. But a lot of the work that also I do focuses on using it as a coping mechanism. And I think I also heard terminology like small T trauma and big T trauma. And we can also use a trauma-informed perspective to address chemsex as well. So one thing I want to start from is this idea that when we talk about drugs and chemsex, I think the narrative has always been, we shouldn't talk about it. It's very taboo. It's entirely illegal, especially where I come from in Singapore, right? If you fly into Singapore on any plane, they'll remind you that there's a death penalty for drugs in Singapore. I think the death penalty applies to drug trafficking, but you don't need to prove that you're drug trafficking. It's you are presumed trafficker by a large amount, having an amount of drugs above a certain threshold. And that is also problematic because I know people who engage in chemsex who hoard drugs because they are so afraid of, running out of drugs as well. So, I think these are some issues that we deal with. So coming from this idea of the narrative on the war on drugs, what has this produced in terms of a lot of our public health research for chemsex? I think scholars have, especially critical drug scholars, have talked about this idea of the rush to risk when it comes to public health. So we tend to think about the risk first when we're in public health. And they talk about how, public health has made important contributions to establishing the link between, for example, meth use and sexual risk-taking, but the precise nature of this relationship is often not well defined. We always immediately think of chemsex and risk, chemsex and risk. This creates space for ungrounded assumptions about methamphetamine use to take hold. I think there are other issues that have been raised also. So we also need to acknowledge that there's non-problematic, so-called non-problematic use of substances. That there's some chemsex that can actually be productive and also to what people think like fun and pleasurable. There's also, we need to reframe the role of drugs as well in sexual behaviors, because if we solely blame drugs for disinhibition and other forms of risk-related sexual behaviors, it actually limits our ways that we understand how to address chemsex or sexualized drug use, by just focusing on that only. And in a related way, we need to move beyond biomedical forms of understanding. The reasons why people use drugs have certain social, political, historical reasons as well. And these are unique to each context. And if we want to address the risks associated with chemsex, we need to better understand some of these, the context as well. And so this is something that I've come up with, I guess, as sort of like a framework to think through, what harm reduction might look like based on some of the different narratives of chemsex out there. And this is actually more informed by, what I hope we can approach chemsex as a person-centered kind of approach, meeting people where they're at. And there are different journeys that structure, how we should approach chemsex and addressing harms related to chemsex. One of them is this idea of the chemsex or sexualized drug use journey. I'll share a little bit more. The second one is definitely the context in which sexualized drug use takes place, because how it takes place and where determines what kind of resources you have to address risks for HIV and other STIs, for example. And the third one would be the personal life course. Chemsex journey is just how people started and where they are at in that journey. But we need to think about trauma. We need to think about life experiences. These are also things that people might inform why people use drugs as a coping mechanism, for example. So when we think about the journey, the chemsex journey, actually what we have seen, because I also help run a community, a charity in Singapore where we provide substance use recovery services, and we've seen people come in. Initially what we did was everyone is an addict, because I came from the 12-step group kind of modality, so like when we started our support groups, we said all use is problematic, and everyone who comes in, you can call yourself an addict. And people didn't, a lot of people were turned away, from that because they didn't identify with that. And if we look at the literature also, and we see that, this idea of problematic versus non-problematic in itself tends to be a little bit problematic, because who defines it, and how do people define it? But I think the common ground beneath it is that if we want it to be person-centered, we have to empower people with the knowledge, skills, the social support, and the resources for them to be able to say what is problematic and not problematic. And I think Dr. Lee in the previous panel talked about some people might not be ready to access services, and this is it's kind of related to that as well. This is from Canada, they have a spectrum of drug use that they also promote in their health systems. There are forms of drug use that, there's non-use, there's certain drugs or psychoactive substances that involve beneficial use. But we think, if we think along the lines of this spectrum, on the other end, it's substance use disorder or addiction. And that's where a lot of our services tend to be focused on. So this is, I just wanted to maybe share this for now. I'll come back to it later. And if we look at this whole problematic versus non-problematic use, there are studies out there that try to research or review the proportion of people who have problematic versus non-problematic use of substances. One caveat here is that these are general population statistics. It might differ from subpopulation to subpopulations, especially for key populations. But what the story that this tells you is that, not all drug use is problematic. And I think being able to identify that will help you reach people where they are at. There are studies also that look at chemsex journeys. So what kind of journeys do people take when they start having chemsex? This idea that you start off with loneliness and emptiness, and then you search for connection, and then after that it becomes problematic, and then the severe health impact. This is actually the kind of journeys that we do see at the center as well. And it reflects a form of coping mechanism and all that. But also, this tends to maybe overemphasize that one end of the spectrum, right? Where it's substance use disorder, dependence issues, and all that. But so the authors here also say that we shouldn't take this as what will always happen. It does not always evolve this way, but it's also helpful to see where people are at in this journey so we can make sure that our harm reduction interventions are at the right place, and what kind of themes do we talk about. This might be familiar to a lot of people doing like programmatic or social work or like psychological interventions as well, the trans-theoretical model of behavior change. And this is the where people are at, if I'm making a change. Is it pre-contemplation? Am I still thinking about it? Am I even before thinking about it? And this is where maybe certain kinds of interventions, like motivational interviewing and like these kinds of interventions that promote or improve motivations for change might be helpful. So if you have a well-made intervention in the community that's like fully, like evidence-based, but you're not meeting people where they're at, it's also not going to work. Okay, so now that's basically the chemsex journey, right? These are all the different considerations that you need to take. Now let's look at the context in which chemsex takes place to make sure that we are reducing harms in that context. So this is a study, I think, published by colleagues in Taiwan and Australia in the Lancet HIV, which looks at harm reduction for chemsex. And they break it down to a very event-based approach. And basically they're saying that when you have chemsex, there are these risks that you need to take care of. One of them is HIV, one of them is the sexual risk, and one of them is related to drugs. And there are all these different things that you can do, to address these things individually, but also these are the things that you need to think about to address, all these reduced harms in these contexts holistically as well. So I think it's actually quite helpful when you're thinking about harm reduction interventions, for people who are engaging in chemsex, to help them make sure that they reduce the harms, all these types of harms that are typically associated with it. One thing about context also is that we've looked at a lot of qualitative research as well, and we noticed that the way that chemsex takes place from one place to another is quite different. And I think being able to know what are the different rituals, how do people go online, what kind of words do they use, like how do people meet, where do people meet, what happens, in Singapore when people have like chem fun or chemsex, like there's also a bit of like card games playing and like a lot of these like social things, right, which are also opportunities to inject certain kinds of harm reduction, like messaging. We haven't been so creative yet, but I think those are all important, right? Because it tells you a little bit more about what people value in these spaces as well, and what access to harm reduction resources that they have. And the third one, looking at life histories. This is some research that we've done at the Greenhouse, which is the community group that I'm with. And we looked at how trauma underpins a lot of chemsex in our clients as well. So like basically there's sexualized drug use or chemsex, but among our clients we note that a lot of this is underpinned by psychosocial distress, sexual shame around their sexual orientation, social anxiety, low self-esteem, loneliness, and then we wanted to dig further, right? Why are our clients facing these issues in such large numbers, huge numbers of like reported forms of like adverse childhood experiences and stuff. And then we realized that a lot of precipitants here are underpinned by forms of trauma, especially small t trauma. So folks who have undergone racism, HIV-related stigma, sexual violence, neglect, internalized homophobia, and all that, tend to present with a lot more of these precipitants. And when we look at the context that we are in, actually in Singapore, people grew up in this context where being gay was criminal, right? I think it was only 2 years ago that we repealed Section 377A. It was actually just like 1 month ago we now don't require people with an undetectable viral load to disclose their HIV status, which is a great advancement in our legal policies. So there has been a lot of discrimination and stigma associated with being gay, living HIV, and all that. And these all underpin all these things, which then weighs down on the idea of sexualized drug use or drug dependence. So I guess to sum up that harm reduction part, like if we're thinking about harm reduction and we look at all these different complex issues around chemsex, I think understanding where they are at in their journey of chemsex, understanding if it's dependence or substance use disorder, like at which stage of change that they are at, what kind of life histories do they have, what kind of traumas do they have, and what are the different cultural practices associated with chemsex. if we are able to understand all these things holistically, I think we are able to better develop harm reduction interventions for people where they are at. And this is something that it's sort of like me putting together all these things that we have presented so far. So, if we wanted to make it maybe a little bit more simplified, we could think about, where people are at in terms of their type of use. There's people who don't use, people who use and they feel that it's been beneficial to them. It helps them connect. It helps them gain more pleasure. There are people who use it, but they expose themselves to risks. There are people who use it and they're dependent on it. I think the approach should be different. And like if we think about people who don't use it, I think it's still important to reach out to them, right? Because a survey that we did in Singapore, basically 50% of our MSM or the gay men in Singapore have ever tried so-called illicit substances. So it's very safe to say that 1 in 2 people will encounter substances in their life. It's just that what kind of context you're going to be in. So having early education programs for young key populations is important because we have to really grapple with this idea that you will encounter drugs. We cannot not talk about it or until after you've encountered it. So what kind of early education programs do we need? And those who are in that space of, I'm kind of using it like once a year. I go to these circuit parties, like in Thailand or Bangkok, engage in a little bit of chem fun, chem sex. It's been very fun for me. I use PrEP, I use, like DoxyPEP, whatever, very empowered people. I think it's also safe to assume that some of them might run into issues time to time. And so being able to still have harm reduction services for them is still important, like the one that we saw in the Lancet HIV Venn diagram, right? Reminding people, don't mix this with that. I've got some examples in the next couple of slides. But when you start to see higher levels of risk associated with use, I think that's where we need to maybe have more interventions. And I'm a bit more familiar with those who are on the right end of the spectrum because that's where our services are. And we do like peer support systems. We are more community-based. We're an anonymous clinic. So I wouldn't call it a clinic. We're an anonymous service, with peer navigators, peer supporters, counselors involved. And so that's where we try and customize care because we really need to get people involved with psychiatrists, psychologists, long-term support groups. We link people up with support groups like Smart Recovery, Narcotics Anonymous, things like that. So I think that's where we need a little bit more intensive programs. So just some examples, I'll breeze through this. So like early education programs, to focus on, what are these common drugs you might encounter, where to find resources if you need them, and also maybe teaching people how to support others. When we give talks like that, a lot of people ask during the Q&A, if I know someone who's engaging in chemsex, like how do I talk to that person? These are all things that we can equip people with. I've seen this being posted. So I think our local NGO posted this once right before like the circuit party season, and they got into a little bit of trouble around it. But this is like a chart that shows you what you should not mix. GHB should not be mixed with alcohol. And all these things. And I think it's in response to the fact that on average every year, we hear like maybe one person dying, from just mixing the wrong things, right? So I think that's an important thing to save lives. Less in Asia, we actually see, so this is the imagination when you think about harm reduction, right? We often think that harm reduction involves like safe injecting spaces and all that, but it doesn't have to be. In Asia, where it's still a lot more punitive context, this is something that we might encounter less. But I've seen some of these interventions in the UK where they use like Grindr, where they know people are using, they are hooking up, with like chem fun or chem sex, and then they provide information there. That's something that you could see as venue-based intervention as well, because we're just not only looking at in-person venues, but online venues too. These are some brief interventions. I won't go into too much detail, but like if you are in a place where you are more likely to see someone with a heightened risk or heightened chance of experiencing harm, in a PrEP clinic, for example, you might be able to have some brief interventions based on cognitive behavioral therapy, motivational interviewing. They've done this for alcohol-related disorders. I haven't seen one for like chemsex though, so definitely an area to do some interventions in. There's also customized care, which I talked about, which we kind of do as peer navigators in the community. So we make sure that, okay, we if you come in and do intake, first we are going to make sure that your HIV/STI testing is done. Link you up with someone who can provide PrEP or PEP. If you need like medical advice, we can actually bring you to a psychiatrist. We don't actually provide those services, but we have a 6-month peer supporter that follows someone through this whole process for 6 months as sort of like a para-counselor. And this is the community group that we have. I won't go into details, but you can find us online, the Greenhouse. And these are all our volunteers and our board. So we basically, our program is based on counseling, peer support, 6 months peer support, 16 free sessions of counseling. We do like horticulture therapy and all that. And it's all entirely free for people because we also, the counselors are also free to us because we are a training site for them. So we partner with schools to do practicum training. We just pay our volunteer clinical supervisor. But yeah, if you want to find out more, you can talk to me during the break or during the Q&A. We also have a guide for how to deal with law enforcement because I think the law enforcement in Singapore is not very friendly. And harm reduction to me is always about, the law can also harm you. So how do you stay safe from the law? It's quite ironic, but it's the fact. Because if you get incarcerated, I constantly have people I know in jail. And I think it's quite tragic, especially when a lot of them are facing issues of homophobia and all that, right? And if you are caught consuming, it's like 1 year in prison in Singapore, and their life basically just crumbles after that. So you're doing more harm than good, right? So I think this is a guide that we decided to do for people on how to deal with law enforcement in different situations. So I won't go into my key takeaway messages, but I'm happy to share the slides around if you want a copy of the slides. But yeah, I think that's all I have for today. Thank you.
Thank you so much, Dr. Tang. I learned a lot. We often talk about harm reduction, but he really gave us a pictures how to operationalize, like into different framework and steps. Yeah. So now we're going to the second part of our mental health sections. It's focusing on the chem-sex the issues. So in these sections, it will be in Cantonese because we're going to explore the narrative approaches working with Canton community in our city. 所以我哋下一個嘅 section 咧係會用廣東話嚟進行嘅。咁咧joining us today is Professor Shelley Hong from the Hong Kong Baptist University as well as clinical psychologist Dr. Barry Tam. And this section will be facilitated by Kensley Choi, our assistant manager of testing and counselling team at AIDS Concern. 咁我就請阿 Kensley 上台就介紹埋我哋兩位嘅嘉賓啦，好冇啊？唔該晒 Kensley。
都可以上嚟就座先嘅，隨便。係咯，咁我都即係好榮幸，今日係即係上午嘅 session， 上午嘅 session 嘅最後一節啦。咁亦都係唯一一節今日係講廣東話嘅一節嚟嘅，係啦。咁就都有少少 recap 啦，即係我都即係聽咗成個上晝嘅時候，我都會不斷去諗，就係其實啲乜嘢都會係拉到落嚟，我哋呢節可以論一論嘅咧。咁我會頭先會寫低嘅就可能 Crystal Lee 都有講到，我喺面對 Canton 嘅時候離開同埋進入好多拉扯喺中間，我哋需要去面對到嘅。咁或者好似Gordon Wong 都會有提到 internal stigma， 即係我哋可能面對嘅唔單止係一個 stigma，MSM 可能係 PHIV 或者都有玩 Canton 嘅一個情況，即係都唔係一啲社會認可嘅一啲 identity 啦。咁呢啲都係即係我哋都要去面對嘅一啲處境咁樣咯。咁我哋即係諗到落嚟嘅時候，我哋就會諗就係都會去一個即係major 呢個主流論述去睇呢件事嘅時候，好似好無能為力咁樣。但係當我哋即係再睇多啲，將呢件事擺喺社會上面嘅時候，又係咪真係咁無能為力呢？咁所以我相信即係呢個係一個原因，點解我哋擺咗narrative therapy 係做呢個 session 做一個討論嘅。咁就都介紹多少兩位即係我哋嘅今日嘅 guest speaker 先啦，係啦。咁就洪雪蓮教授啦，咁而家就係浸會大學度工作嘅。咁係呢個社會工作實踐及精神健康中心嘅中心主任啦，係咯。咁主要嘅研究項目都有呢個婦女同家庭性別暴力，跟住小組工作同埋社區發展啦。咁最重要就係都有敘事治療嘅一個部分啦。咁喺幾年前Professor Hong都同呢個 Project Hero 做咗研究，咁就係關於呢個 敘事治療同埋於呢個 CAMFUN 社群嘅應用同埋實踐嘅。陣間洪教授就會 share 多啲㗎啦，係啦。咁另外就 Dr. Barry Tam 啦，咁佢就係個臨床心理學家嚟嘅，咁就係而家喺一個本地嘅醫院度工作啦。咁佢嘅服務對象都包括即係 HIV 感染者啦。咁大家可能即係坐咗成個上晝嘅 session 都會知道，其實HIV 感染同 CAMFUN 都有一個都叫做密不可分嘅關係喺入面啦。咁所以喺佢嘅日常嘅工作裏面都會接觸到可能即係HIV 感染者加有 CAMFUN 呢個hobbies 嘅習慣嘅一個服務使用者咁樣樣咯。咁所以咧，我哋就喺呢個 combination 裏面咧，陣間就會Dr. Tam 就會再講多啲佢可能臨床工作裡面嘅一啲遇到一啲個案嘅一啲情況啊，或者佢哋一啲諗法咁樣樣嘅，係啦。咁我都又介紹下自己啦，我係 Kensley 啦。咁好似 Lida 頭先所講，我就係呢個testing and counselling team 嘅一個 assistant manager 啦，暫時咁樣樣係啦。咁就點解會揾我做 moderator？咁我諗係我自己對呢個題目都有啲熟悉啦，咁樣樣咯，係啦。咁亦都工作咗好多年，亦都會喺嗰個工作上面會遇到呢個社群嘅一啲人士啊，或者會接收到唔同面向嘅一啲 information 左右咁樣啦。係啦，咁所以都好開心，今日就有呢個機會可以同兩個大師交流一下啦，咁樣。係啦，咁就都講咗一大段嘢啦，咁都想拉翻即係兩位啦，因為我都會有聽到有啲人會講呢個narrative approach 係一個即係敘事治療嘅一個名稱，或者佢會講就係叫做敘事實踐。咁我都想問翻Shirley 係咪有咁叫你？
我經常強調佢叫我 Shirley 得㗎啦。
即係呢個叫法上邊有冇啲咩唔同啊？或者你自己取向於點樣去叫呢一樣嘢咁樣
？OK， 其實 Kensley 太謙虛啦。其實佢唔係即係有認識，佢係好有深入地認識係啦。因為佢都係做咗敘事治療好耐嘅係啦。咁咧就我自己嘅理解啦，因為都冇乜嘢學術文章啊睇到，即係講 narrative therapy 同 narrative practice 嗰個嘅即係起來源或者個分別咁樣樣。咁我自己嘅理解嚟嘅啫嚇，即係大家可以一齊去諗下傾下。咁咧就係我嘅認識裏邊咧就係 Michael White 啦，大家都聽過啦，佢就係敘事治療嘅一個即係創始人啦嚇。咁佢本身係一個社工嚟嘅，咁同埋佢都係一個 family therapist 嚟嘅。咁所以敘事治療嘅開始嘅時候咧，其實係由家庭治療嗰個系統嗰度走出嚟嘅，即係佢係喺佢本身係一個家庭治療即係嘅人啦，咁所以佢喺嗰度去一路發展一啲新嘅諗法。咁當然佢喺嗰個系統度走出嚟咧，但係其實佢都係顛覆緊家庭治療嗰個諗法，傳統即係家庭治療嘅諗法。咁所以其實我自己聽一路學佢都係一個 therapy 嚟嘅。咁但係大家又都好明白咧，就係話對 therapy 嗰個諗法咧，其實喺傳統一路以嚟咧，其實都相當狹窄嘅。即係我哋對家庭治療嘅理解或者個人治療嘅理解咧，一般都會係諗即係有個專家，然之後坐低就同一個即係受服務嘅接受者咁，然之後我哋要了解佢個問題，然之後我哋俾好多嘅 advice 佢，然之後睇下點樣幫到佢咁樣樣係啦。咁個 therapist 又好叻嘅，咁係咪？即係我哋又知道好多嘢嘅咁樣樣。咁同埋都係基本上可能會個焦點擺咗喺個人嗰度，即係甚至乎可能一啲內在嘅嗰個人嘅內在嘅一啲嘅問題啊、欠缺啊，或者佢一啲嘅諗法有啲咩唔 OK 啊咁樣。咁呢個係傳統我哋對治療嘅一個比較即係窄嘅理解啦。咁去到敘事治療咧，因為其實佢嗰個背後嗰啲諗法咧，或者我哋成日講個哲學咧，其實就係話佢係睇多啲其實即係人嘅問題唔係佢自己喺個內在度產生出嚟嘅好多時，而係經過社會好多嘅即係文化上高嘅影響啦，或者好多即係制度嘅影響啦，好多嘅影響之下咧，令到嗰啲問題係咁樣去呈現嘅。咁所以其實敘事治療係好強調咧，就係話即係一個即係文化嘅 建構啦嚇，一個社會嘅建構啦，對於問題，咁佢哋會講多啲係即係個社群點樣去面對呢樣嘢，或者我哋集體一齊點樣去面對呢樣嘢。嗱喺呢個環節咧，你就會見到佢超越咗即係傳統，或者佢挑戰緊傳統所謂治療嗰個嘅理解啦，嗰個概念啦。咁所以我哋開始就用實踐呢個名詞，因為呢實踐係闊啲啦嚇，即係 suppose 我哋係你個人又得，家庭又得，群體又得，係啦。咁亦都可能即係跳咗出去，即係多少少唔係傳統嗰種對治療嘅理解啦。咁但係今天我哋兩個名詞都仲用緊嘅，即係你會見到我哋又用 therapy 又用 practice。咁如果你問我咧，都係個人理解我就覺得咧，我哋仍然覺得佢係一個 therapy 嚟嘅。係啦，但係佢唔係一個我哋一般理解嗰種 therapy， 但係佢仍然係一個 therapy。而我覺得好重要，仍然叫佢 therapy 嘅意思係好 political 嘅，好政治性嘅，就係我哋要 speak to 個 therapy community。即係好多 therapist 佢如果你話俾佢聽呢個唔係 therapy 嘅話咧，佢完全唔會有興趣去知道你係做緊乜嘢，或者你挑戰緊啲乜嘢。所以我哋係要喺翻即係治療嗰個系統裏面嘅世界裏邊去做一啲影響嘅時候，即係我會仍然即係會我哋仍然會叫佢做 therapy。都幾 political 嘅考慮，如果你問我。咁但係同時間我哋又會叫佢做 practice， 因為佢真係超越咗即係我哋好狹窄嘅一個對治療嘅理解咁樣嚇。
明白，即係我都係走出輔導室以外，都有社區層面都有啲 intervention 嘅一個 approach 啦。但係要翻返去治療嗰個界別嘅時候，我哋有一次有少少無可奈何地，我哋要用到即係治療呢個字眼。咁我都會想問下 Barry， 你都會喺個治療嘅系統入面㗎嘛？咁你會點樣 prefer？
好治療嘅一個系統添，即係入到嚟係啦，即係嗰個樣都嗰間房完全都唔似係唔治療啦，係咪？咁但係我有時覺得係即係除咗敘事治療或者敘事實踐，我覺得係敘事嘅哲學嚟嘅。即係我估係我哋點樣睇事物嗰個態度，其實好反映到我哋點樣去用乜嘢嘅方法，用乜嘢嘅角度去同我翻嚟見我哋嘅人去傾偈嘅。咁所以我估嗰個哲學係即係好似頭先 Shirley 咁講，係佢係挑戰緊個傳統或者顛覆緊個傳統。我傳統地我臨床有心理，梗係成日就話人有病呢樣病嗰樣病咁樣。咁即係病人會同我講話其實我唔想再見到科啦，即係已經夠多病㗎啦咁。咁我即係如果我仲係用一個病理嘅角度咧，就真係講客嘅，即係冇人想翻嚟見我。但係如果帶住一個即係敘事嘅哲學去睇嘅時候，即係會令到佢哋翻嚟見我嘅時候，會覺得原來係傾一啲關於佢嘅事情，唔係傾關於我想傾嘅佢有咩症狀、有咩病理。對於翻嚟見我嘅人咧，會舒服好多。所以我有時覺得係嗰個哲學嚟嘅，係一個即係我哋可唔可以喺睇佢嗰個所謂嘅問題裏邊，我可唔可以睇到一啲另外一啲嘅方法去理解呢件事咧咁樣。
明白。咁頭先兩位都各自有提到顛覆一個即係以前一個諗法啦，即係唔係話我由一個 counselor 主導，或者我一個治療師作為主導去評定人哋我有冇病，你需要幫助，我點樣去 diagnose 你咁樣啦。咁我都想請 Shirley 可能 share 多啲，其實NT 或者 NP 啦咁嗰個 concept 啊，或者論述會係點樣樣？可唔可以講多少少？因為未必個個都知道。
同埋我覺得係特別適用於特別好地，亦能夠應用於好似 Barry 講，就係當我哋做一啲cam 分嘅一啲朋友啦嚇，或者係HIV 啦，或者係即係同志嘅群體啦咁樣樣。咁我覺得佢個理念好特別嘅地方咧，就係通常呢啲朋友嚟到我哋嘅時候咧，其實佢哋都會係已經好似頭先 Barry 講，見過好多專家㗎啦。咁然之後佢哋自己都內化咗，即係其實嗰啲問題係我嘅問題，點解咁耐都戒唔甩咧？明明知道嗰樣嘢唔好，你又點解停唔到自己呢？呢啲都肯定係你有問題㗎啦，即係唔係其他人唔幫你，或者即係而係你自己要一個好大嘅即係責任，係你自己搞唔掂自己咁樣。咁嗰種 self stigma 同埋嗰種即係內化自己嗰種問題係好強好強。咁敘事治療有一個好嘅地方咧，就係話即係佢覺得人唔等於個問題啊嘛。個問題係問題，人唔等於問題嘅時候咧，佢就將個問題同個人分開咗，以至於嗰個人咧可以比較客觀地或者一個距離地去睇，其實嗰啲問題係點樣出現嘅咧？ 嚇，即係最開初佢去接觸 camphor 去接觸 drugs 嘅時候，好多故仔嚇，點解會開始呢樣嘢呢？嚇，嗰個背景係點樣樣咧？佢碰到啲乜嘢問題喺嗰個乜嘢嘅處境裏邊？我哋都好了解，即係我諗今天大家一路聽好多就係同志嘅群體，如果佢係 take 埋 drugs 係咪？然之後佢再有埋 HIV， 即係我哋成日話佢都唔知幾多層嘅即係標籤嚟嘅，係嘛？即係佢喺一個咁樣嘅處境裏邊，其實佢好難去覺得自己仲有辦法，仲有能力。仲有希望係啦，咁敘事就話俾佢聽，其實唔係，即係你個問題嘅出現有一個背景喺度，有一個 context 喺度嚇，嗰個唔係淨係你自己有好多問題，你自己嘅完全係病態咁，所以你進入一個咁樣嘅狀況，咁所以我哋將問題外化嗰個做法，其實就係講緊呢樣嘢咯。咁另外就係嗰個我哋講好多係社會建構嘅理論啦。同埋就係後結構主義嘅理論啦，咁其實都係講緊就係話，即係頭先講問題係好多嘅因素喺裏邊，包括我哋成個社會嘅文化，我哋社會嘅一啲嘅做法，一啲 practice， 其實都係製造緊呢啲問題嘅咁樣。咁另外就仲有一個好嘅地方，我覺得即係敘事嘅理念咧，佢就話佢唔會睇一個人係完全冇能力處理佢嘅問題。即係佢唔係坐喺度等死嘅，講得衰啲，唔係冇一個人會坐喺度讓個問題完全控制佢，然之後佢一啲嘢都不能夠抵抗到。咁敘事就好重視，就喺我哋叫重寫生命故事嘅時候，我哋就去揾翻其實每一個人一定有好多嘅能力，有好多嘅知識技巧，去讓佢一路點樣去處理呢啲嘅問題，或者減少呢啲問題對佢嘅影響。而更加緊要喺敘事裏邊咧，佢就係講一個人嗰個身份認同。即係嗰個 identity 啊，嚇！即係你見到即係大家一定會想象到呢啲朋友佢嗰個 identity 係一個 problem 嘅 identity， 即係充滿住問題，或者個 failure 嘅 identity， 一個失敗嘅身份。我從來都冇成功地離開過 camp， 即係呢個一個好 spoiled 嘅 identity。其實喺敘事裏邊，佢哋就會透過譬如重寫生命故事或者好多其他嘅方法，讓佢睇到，喂，你唔係乜嘢能力都冇，你唔係冇努力去應對你嘅問題，你唔係冇嘢改變過，即係呢份問題最嚴重嘅時候，同你現在可能已經係有一個好大嘅分別喺裏邊，係啦。咁所以我自己覺得真係好適合，即係敘事嘅諗法係好適合，即係喺呢啲群體裏邊去用咯。嚇，
都明白嘅，即係會睇到就係即係唔好將個問題歸咎於個人身上面，都嘗試去外化去睇翻呢一件事，再去揀一啲即係自己嘅一啲 unique outcome 擺翻落自己 story 度。咁我記得我之前同Barry 去 Zoom 嘅時候都有提及嘅，我點樣寫傳記啊？點樣去幫點樣可以協助嗰個人去 pick 一啲佢嘅story 一啲最 sparkling moment 抌入擺翻落去。我都想你 share 多啲呢方面嘅一啲情況，即係當你即係入到呢個輔導室入面，即係都想同嗰個個案去 go through 呢個 session 嗰個 journey 嘅時候，你自己會係點嘅取態嘅咧？咁樣
我都好多時即係病人翻嚟，梗係見我嘅時候就梗係自動咧就已經喺度即係自首啦，或者嗰啲即係告解啦，咁啊將自己過往犯嘅事就要寫晒出嚟啦，講晒出嚟啊咁。咁但係喺嗰個時間，其實我有一個好秘密嘅工作，就偷雞咁樣做緊嘅。其實我就要喺度剪裁緊一啲有用嘅材料，係愛嚟準備我之後要同佢即係用一個 narrative 嘅方法去傾嘅。即係例如一啲對於佢嚟講好重要嘅人，或者有啲乜嘢佢好似堅持住，或者佢永遠都唔肯 let go 啊，或者佢好即係嗰啲事情好似睇落去有啲脈絡係。睇落去好似唔係好明顯，但係又好似有啲嘢佢好似一致地會做緊嘅。咁嗰啲我可能會有個好奇心，就係之後可能喺嗰個嘅治療裏邊嘅時候，即係所謂嘅治療裏邊咧，我哋會做到咁。咁有時我估係啦，我要擺低個專家身份啦，即係所以就叫佢哋叫我名嘅。咁所以咧嗌我 Doctor Tam 咧，佢哋唔知邊個嘅，但係講 Barry 咧，佢哋知係邊個啦咁。咁都係令到喺房裏邊嗰個嘅權力咧冇咁唔一樣。 如果嗌我 doctor 乜，即係我話乜就乜啦咁佢真係嚟自首啊！我變咗神父啊咁但係就唔係嗰件事嚟嘅。但係如果當佢真係嗌我名嘅時候咧，大家一齊去共建呢件事，就令到我哋去做即係重寫翻去生命故事頭先 Shirley 講嘅嗰個部分咧，就會易好多。咁有時我哋會形容嗰部分咧，我係陪佢哋一齊去寫翻佢哋人生嗰個嘅傳記去自傳。我有時會比喻我係個記者嚟嘅啫，其實我幫手去記錄低啲嘢。而佢好多時因為翻嚟講古仔俾我聽嘅人咧，佢都會講肉眼世界見到嘅嘢啊，發生咗咩事喺佢身上邊啊，跟住佢又點樣啊？嗰啲嘢都係佢對眼見到，但係好多關於佢內心世界，即係呢啲肉眼世界發生嘅事，點樣影響到佢內心世界嘅諗法啦、感受啦？佢有啲乜嘢想去做啦？佢盼望啦、佢嘅期望啦，或者佢一啲嘅夢想啦，佢都未必有機會講，但係我就可能會透過我作為一個記者幫佢去筆錄嘅時候咧，我就可以去提出呢啲問題，用我嘅好奇心幫佢豐富翻呢啲資料，令到佢寫出嚟個古仔，再唔係我係一個我上癮咯、導遊咯、我就感染咗咯、我就基嘅咯咁佢就可以寫翻另一啲嘅古仔出嚟，其實係講緊佢佢可能聽落去都可能同你同我嘅古仔係差唔多嘅。都有一啲好令到人感動，佢有佢好獨特嘅一啲嘅身份嘅啲古仔出嚟，咁所以有時呢個就會係我做嘢上面嗰個角度。
明白，都好豐富啦。即係作為一個治療師，其實又唔係治療師喎，都會係一個作者或者筆錄嘅人員去記錄翻即係回顧翻佢過去嘅時候一啲可能即係已經被人遺忘咗，但係其實都好重要嘅一啲經歷擺咗喺度，再去重新拾翻自己嗰個 preferred 嘅，即係個想要嘅身份，再點樣去睇翻將來啊，帶來一啲希望啊，點樣再行以後嗰條路啊等等。咁我都有啲問題寫咗嘅，所以我都要問埋先嘅，係啦。咁你哋覺得啦，敘事治療或者敘事實踐啦，適唔適合 apply 喺即係 Camp 呢個 community 啦？咁同埋有冇一啲個案你都印象深刻，其實都會想可以喺度可以分享到嘅咁樣，係啦。邊個先 ？Shirley 先。
適唔適合咧？我頭先即係連帶都講埋，係啊，即係介紹嗰啲基本嘅諗法，即係概念嘅時候，即係連帶都講話點解佢會咁特別適合，即係我哋叫一啲叫小眾嘅群體，因為小眾嘅群體喺個大社會裏邊係好難去講佢哋嘅故仔嚇，即係冇人有興趣聽，或者講已經引嚟好多嘅即係 judgment 判斷，咁所以其實係好困難嘅，即係但係我諗敘事實踐係俾佢哋有一個空間，我哋係即係我哋嘅責任係即係製造一個空間，讓佢哋有機會去講佢哋嘅故仔，唔使喺好大嘅壓力底下被批判嘅狀況底下去講佢哋嘅狀況，然之後即係佢哋都其實有好多嘅意見嘅，對於我哋而家嗰啲即係社會服務啊，對於我哋嘅社會制度啊，其實佢哋好多意見。咁譬如乜嘢令到一位男同性戀者佢覺得咁難去建立親密關係呢？點解要用呢啲方法，某一啲嘅方法去揾 partners 咧？咁其實呢個唔係佢淨係講緊一個個人嘅選擇嚟，而係喺我哋成個社會裏邊點樣去對待呢一啲嘅群體。我哋俾咗一啲乜嘢嘅限制，俾咗一啲乜嘢嘅即係壓力俾佢哋，令到佢哋即係只可以喺一啲好有限嘅空間裏邊去，其實做緊一啲我哋覺得每一個人都應該有權或者有權利應該可以享受嘅一啲嘅即係與人相交或者去建立關係嘅一啲嘅即係空間咧咁樣。咁我諗敘事治療係好好嘅，因為我自己過去嘅經驗同 Barry 有啲唔同嘅。Barry 就係個人多啲嘅，我自己係做即係社群敘事實踐多啲 collective narrative practice。咁我做法咧就係擺喺小組或者擺喺個社區裏邊去做嘅。咁個效果係好唔一樣嘅，就係話即係其實佢哋自己嗰種故事嘅分享一齊去重寫一個故仔，而重寫嘅故仔唔係淨係個人嘅故仔，都係呢個群體嘅故仔。咁所以我哋好多時除咗話講個人嘅故事，然之後每一個人再重新點樣睇自己嘅身份之外咧，我哋仲會做多一樣嘢，就係話你點樣睇呢個社群。 即係我哋有一班人而家喺呢度，透過我哋呢啲嘅故事嘅分享，睇到我哋其實好有能力。我哋對關係，對我哋喺呢個社會裏邊嘅角色，我哋對好多嘢我哋都有希望嘅，我哋有憧憬嘅。帶住呢啲嘢，我哋會想點樣去影響嗰個即係世界，即嗰個就喺一個集體嗰個層面裏邊就能夠即係做到呢個嘅效果嚇。咁所以即係我真心地覺得係好適合嘅。
明白，即係個人有陣時候，你諗即係個人嘅力量可能比較單薄啦。我哋透過集體敘事嘅時候，亦都可以去再加強翻我哋一啲即係力量去面對同一個問題啦。我哋可能咁樣去諗呢件事。咁可能就落翻個人嘅時候，我喺輔導室裏面有冇啲個案你都可以分享一下咧？
都有嘅，即係我唔可以講得太仔細咧，但係即係都令我諗起有一個個案係即係佢開頭翻嚟揾我嘅時候有 camp 分啦，咁當然亦都係感染咗啦。咁開初佢其實做一份佢唔係太喜歡嘅工作，咁佢又喺嗰份工作上面即係都令到佢有情緒好差啊，每日真係到要翻工嘅時候會 panic attack 啊咁樣，咁結果跟住變咗做 long term sick leave 啦咁樣，咁但係喺裏邊即係佢好努力試過好多次想嘗試去翻工，但係都係翻唔到，但係佢又 keep 住呢份工，我都有啲諗，咦，其實都幾特別，我都拖咗好耐，但係佢仍然好似好想堅持又翻呢份工，但係佢又翻唔到。我反而就好奇，其實如果唔俾呢份工鎖住嘅話，佢會做啲乜嘢咁？咁佢就講起其實佢想做某一個助人嘅行業，但係礙於佢某啲嘅原因，令到佢覺得有啲嘢佢怕嘅，咁佢覺得佢會做唔到嘅。咁啊唔緊要啦，後嚟咧就疫情開始啦，咁啊佢又俾人肥雞餐咗啦，咁啊攞住筆錢就唔知可以做乜，咁佢一日突然間諗，不如試下讀啲課程，試下會唔會可以做到啲其他嘅助人嘅行業啦咁樣，咁跟住又俾佢竟然即係都揾得到，咁但係即係佢讀到，然後跟住再揾到一份即係初階嘅工作，咁佢發覺咦原來佢開初擔心佢做唔到助人行業嘅一個恐懼，原來係唔存在嘅咁，甚至乎喺裏邊佢講咗一個故仔俾我聽。佢點樣陪一個佢幫嘅人？嗰個病人都即係佢幫嘅一個病人係已經係末期嘅即係病㗎啦咁每日都淨係攤喺張床就唔喐咁樣。咁佢每日就去撩佢講嘢，然後就嘗試氹佢落床行咁樣。咁佢氹咗幾日，跟住個病人終於頂佢唔順，就陪佢行下啦咁。咁跟住越嚟越行得多，跟住佢哋兩個其實亦都每次行路嘅時候會傾下偈。佢喺個過程裏邊其實雖然好似話聽呢個故仔佢幫緊個病人，其實呢個關係呢個經歷都幫緊佢，令到佢重塑咗一個新嘅，即係喺呢個新嘅關係裏邊，佢揾到一個新嘅身份出嚟。原來佢都有能力幫人嘅，原來佢都可以成為一個即係助人嘅人嘅咁。咁喺呢一度就開展咗佢一個新嘅一個故仔。咁之後佢就真係成功成為一個即係助人嘅行業嘅人員咯咁樣咁。係呢個都係我諗起即係可以話 individual 嘅工作上面會有嘅即係 narrative 可以幫到嘅嘢。
明白，不過呢個都 remind 咗少少嘢，就係有陣時我哋會諗就個人嚟到輔導室去見我哋嘅時候，好似治療師去幫緊嗰個人，其實有陣時我哋就會諗，可能嗰個 story 帶到幫到好多 reflection、好多 impact 喺入邊都唔定嘅時候，所以有陣時就係一個互動、一個交流嘅狀態咁樣咯。咁我哋時間係有限，同埋我諗大家都肚餓啦，咁所以我哋 wrap up 咗少少就係有冇一個即係 take home message 會俾到大家？要重中之重，要記住，呢個係好重要㗎。你嚟過呢度，你就要有粒種子擺咗你腦度啊！有冇呢個 take home message 俾到大家咧？
佢其實我哋傾偈嘅時候講多咗好多，不過點解突然間要我講一個重中之重咧？就大家唔識講添。咁咧就我諗都係我諗敘事實踐或者敘事治療真係影響得我自己好緊要，就係喺過去10幾20年，我諗我即唔係淨係一個工作嘅方法，而係真係影響埋我自己一個人，即係作為一個人嗰個價值觀或者我自己個世界觀係點樣樣。我覺得即係會好希望同大家分享嘅就係話其實我哋 其實我哋自己唔係好叻嘅啫，真係好多嘢我哋都係透過聽好多嘅故仔，即係願意好多人願意同我哋分享佢嘅故仔。呢個係一個優越嚟嘅，我自己覺得即係。但係我自己會係經常做一樣嘢，而我知道好多人好多專家都係好困難去做一樣嘢咧。我係會向我嘅服務對象，我會向同我分享佢故仔嘅朋友去acknowledge， 即係去確認其實佢對我生命嘅貢獻喺邊度。即係我覺得我哋真係喺呢度，我哋喺瑞士裏邊，佢有一個概念就係話個 self 係 relational 嘅，即係每一個人個自己係一個身份係一個關係性嘅，即係你唔係坐喺度諗自己係一個點樣嘅人，你係喺個相交裏邊喺個互動裏邊去建立你自己嘅身份。咁所以如果你有呢個諗法嘅時候，我哋同佢哋大家一齊或者大家一齊去 interact 嘅時候，其實咪互相建立緊嗰個身份咯。咁所以佢有一個概念咧，就係我哋嘅 self 係即係 mutually constitutive 嘅，即係我中有你，你又中有我，即係你影響緊我係點睇自己一個點樣，我影響緊你係一個點樣嘅人。咁所以我自己喺我自己嘅工作裏邊咧，我係不放棄任何機會，或者我係好願意去向我嘅所謂 client 即係去話俾佢聽，其實你都 contribute 緊 to 我嘅生命或者對我嘅工作嚇。呢樣嘢我係好願意同大家分享嘅，係啦。
我好簡單嘅啫，就係我覺得人生係本傳記嚟嘅。咁經歷咧，我哋改變唔到，但係我哋可以選擇寫啲乜嘢落去呢本傳記度。咁我就希望即係大家同工可以幫翻嚟見我哋嘅人，去做翻佢哋自己本傳記嘅主筆咯。
多謝晒兩位。我哋仲有 Q&A 嘅，
大家會唔會太肚餓？
唔會太肚餓。好快，我哋 I think we can still have like 5 minutes like Q&A Q&A section. So I would like to invite Dr. Tan 上埋嚟。我幫你。
啊，係喎，仲有一個
一齊坐啊！一齊。OK。有個麥。我驚你哋都好多互相有問題，我 feel 到會可能。Anyway, so any questions? We have like 5 minutes, and then yeah. So take your time. Any questions?
大家都肚餓啦，可能。
我問一條得唔得？
可以啊，梗係可以。
我好中意呢個 session，因為我係好 believe in narrative approach 嘅。當然喺香港個環境咧，最大嘅問題就係即係經常你同啲醫護人員講，就係會覺得我哋冇時間咯，去做呢啲咁詳細嘅工作。narrative approach 你要去真係好有耐性。去聽人哋嘅 story， 再去 discern 究竟呢個 story 裏邊有一啲乜嘢嘅含義喺裏邊啊，佢個 personality 係點啊，點解佢會 arrive at 呢一個咁樣嘅 decision 等等，呢啲非常之有用嘅嘢。你哋作為 practitioner of 呢個 narrative approach 嘅人，你會唔會覺得可以去 advocate 翻俾policy makers， 睇下點樣可以改變個 social environment， 其實呢個係今日其中一個 theme 啦，去 facilitate 即係一個 environment 係 conducive， 可以做到呢啲咁有意義嘅工作咯。Thank you。
我呢啲喺個食物鏈下邊嗰個階層咧，我唔知答唔答得啊！即係我都好想，即係其實就係我啲同事冇機會做、冇時間做咧，我先有機會做。即係如果佢哋有時間做咧，我就冇機會做㗎。咁我冇機會聽到呢啲古仔。的確翻去，即係如果我着翻套制服咧，我就要跑數嘅咁。咁我估喺公家裏邊，我哋真係好難去即係希望每一個同事都做得到，因為我估呢個係一個社會論述嘅問題。我哋呢個 KPI 呢個係我哋好緊要嘅一個 dominant 嘅 discourse 嚟嘅咁。但係我估有時個narrative therapy， 我估佢未必一定要係我哋傳統諗嘅嗰種 therapy， 即係坐喺度50分鐘嘅一個 therapeutic hour 咁。咁啊，我印象中我學 narrative therapy 嘅時候，我接觸我老師丁媽咁。 同佢其實由一個課室行去另一個課室咧，就傾嗰陣就已經 narrative 咗啦。有一次我約佢行山，因為咁啱我約佢行山前就發生咗啲事，唔係好開心。全程佢都冇同我講過問題嘅，但係落完山之後咧，我就突然間如沐春風。即係佢冇同我討論過問題嘅，但係突然之間我就落山嘅時候就好多 reflection。我估所以其實未必係一定要用嗰個形式或者嗰個局限嗰個框架底下點樣做，而係頭先我講嘅敘事係一個哲學嚟嘅。如果大家有嗰個哲學，即係李小龍咁樣四兩撥千斤咁，你乜嘢都可以四兩撥千斤嘅。你唔一定要著李小龍裝，有個雙截棍先可以四兩撥千斤。你可以平時都可以做到呢樣嘢，即係可能一個護士嘅同事幫個病人抽緊血嘅時候，同佢傾偈嘅時候，其實嗰個敘事嘅哲學都可以一樣出到嚟嘅咁樣。咁而敘事治療從來都冇話要一個註冊嘅敘事治療師嘅原因，係因為係每一個人都可以成為一個敘事嘅 conversation partner 嘅咁樣。所以我估呢個都可能係跳出個 KPI 以外，我哋可以去思考點樣將呢啲 skills 或者個哲學帶落去我哋每一個做呢個行業嘅人咯。
Maybe sorry. Yeah, I just want to translate, a little bit, so that Dr. Tang, maybe any input, in the Singapore context, because we've been talking about like how to use, been using like narrative practice sometimes in the system, like it takes long time to talk to the service user, and sometimes the KPI or environment may not allow that. Is there any way that we can advocate, like system and the people, practitioners, like how to adopt some of the approaches, for example, like narrative approaches, and also I think the approaches that you mentioned, the trauma-informed, approaches, etc. How to, advocate, like the environment, the medical professionals in a very stressful environment, but still they can do something, any experience? And 大家互相夾。
我哋講埋 narrative 就等啊，可以講嘅。非常之中意呢個提問，因為其實咧，我自己大學裏邊係教敘事㗎啦。咁人哋咧，我有 counseling 嘅學生啦，有社工嘅學生啦。其實佢哋成日翻嚟都係話俾我哋聽咧，就係話佢一去到翻機構做嘢嘅時候咧，或者特別做實習嘅時候咧，佢哋就碰到好大嘅問題咧，就用敘事填唔到啲 form 嘅。咁就因為大家都知嗰啲 form 嗰啲 intake form 啊，嗰啲全部都係要佢填，譬如話你覺得佢個問題係乜？係啦，即係我哋好快要做一個即係problem 嘅 assessment， 或者你要話佢個問題喺邊，然之後你要話你個 treatment 係乜嘢，你個 intervention 係乜嘢。咁敘事咧就都係有我哋好啲比較特別嘅脈絡㗎嘛，即係我哋唔係行入去就問你個問題喺邊，我哋就調翻轉，可能就係話覺得呢個問題唔係你個問題，然之後我哋大家一齊去傾下呢樣嘢咁。咁所以係真嘅，即係好多喺 NGO 嘅 context 或者我唔知 medical 係咪都有咁嘅狀況咧，就係話其實啲上司或者係啲 supervisors 冇乜呢個耐性嚇，即係你唔好話俾我聽，你同佢傾好多個 section 之後先講到俾我聽，即係你做緊啲乜嘢咁樣。咁而家我都俾我自己一個挑戰嘅，我就開始諗咧，我點樣可以即係同大家分享到，或者我哋一齊去諗下，就係一啲好 conventional 嘅 service setting， 或者係佢唔係好覺得你要用呢啲嘢嘅時候，我仍然好似頭先 Barry 講，我都能夠擺到嗰啲概念落去，然之後我又交到功課嘅。即我而家係俾我自己，因為年啲學生都嚟問，一出實習就做唔到啦。佢哋好中意呢個 approach， 個個都話要做。但係一落到機構一做 counselling 做唔到，因為佢答唔到嗰啲問題，係啦。咁我而家開始諗我點樣去預備到，要同阿 Barry 分享。
版嚟嘅啫，版嗰啲點樣寫其實睇過。
冇錯啦，即係叫佢哋可唔可以即係唔好咁 serious about those reports。I'm sorry。我都係有份問阿 Kensley。個 outcome 咧用呢個 approach 你會諗點樣 narrate 個 outcome 俾我聽？你可以用 narrative approach， 你要 narrate 個 outcome in a systematic way so that I can talk to the funder, I can talk to the people。係啊，我係。trauma 嚟嘅呢個。Another question inform 我同你傾嘅時候 ，OK。Another question that we have been asked always is about evidence of effectiveness. So we are always asked, are there any research studies that you can prove the effectiveness of narrative therapy or narrative practice? But to be frank, actually we are not a little bit, very much underdeveloped in terms of doing scientific research because we don't agree with the ideas of scientific research. We are not CBT, we are not some of those very long history approaches that were well established in terms of research findings and so on. So that's one of our disadvantage, I think.
No, I'll keep it really short, but I heard, was it 15 minutes? Something about like how long it takes to do narrative, like.
It could be long, but it could be short.
Right.
Yeah.
Okay.
It doesn't really take any specific time to really do a session. I mean, we sometimes call it a conversation rather than really a therapy, because I mean, like, you can bring in the philosophy into the conversation without really thinking about, like, you have to do. We don't have an agenda like CBT.
Right.
I mean, in narrative therapy.
Okay.
That makes some sense.
Yeah, I think, I don't know, because I do some research on like integration, and I think about like maybe community-led kind of approaches, and how communities can help enhance health systems also, because not everything has to be done by a physician, and I think a lot of times it's the policies that say, oh, physicians must do it, but I've seen models where communities take parts of it that, or they are supervised by a physician. So I wonder sometimes whether for some of different approaches, whether there's also a possibility where like aspects of it, you can task shift, shift the task to like some other people. I mean, there are also expertise in, like, I'm pretty sure like narrative approaches have its own like expertise that you need to be trained in. I think you cannot take that away from people who are trained in like psychotherapy, but thinking about how everyone can work together, it's not just a job of the therapist or the physician to make things happen. I think we often forget that, but I also know that sometimes policies prevent us from going there, and KPIs also prevent us from doing that.
It's very off-putting.
Thank you so much. Actually, what Dr. Tang shared, we will continue the discussions in this afternoon, because we'll be talking about like how the GO NGO can work together to create or co-create a service model. So, okay, thank you so much. Thank you. Okay, 我知道大家好肚餓㗎啦，咁而家咧就係lunch hour, so we'll have like 1 hour. Okay, so we'll be back in an hour, and then we'll have another discussions on the physical health and the social health. Thank you.
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will